Check this. Hello. Hello. Check. Check. Check.
टी कॉफी काउंटर इज ऑन प्लीज सेल्फ सर्विस है प्लीज हैव योर टी कॉफी वी आर going to start sharp at 10 o'clock only 4 more minutes to go so grab your cup from the counter which is on the back side of the hall.
Don't be sad, don't you cry.
Hello. you very much, dear Mumbai and dear Mera. And a very, very warm welcome to all the delegates. And we really thank you all from bottom of our heart for coming for this very special event for all of us. At the outset, let me thank our sponsors without whom this program wouldn't have been possible. संदीप जी आपका चेहरा दिखाइएगा. मिस्टर संदीप दास of Ad Age, उनका प्रॉमिस है he simply adds age to your life. तो then also we have सुरेश गुप्ता जी, शायद अभी पहुंचे नहीं है, but he is from the Sleep Secure. Then we have Aditya Verma, he is from the Evron Biocraft. Special thank. अब आदित्य आपका चेहरा भी दिखाइए, कहीं कहाँ छुपे आप. पीछे ही है. These are all channel partners I am introducing to you because they are the ones who actually execute the sleep studies. They have the devices with them, which are the mainstay of the treatment of sleep apnea. And they have been really courteous to all of us. And it is important that their services are also appreciated by we all. So Aditya has in fact actively helped us in even organizing the program. Every minute details I have discussed with him. And thank you for all that you have done for us. And we have a new entrant to the field, Soumya Ranjan Sahu. His company name is Sleep Remedies. So he's also been a very dear friend to me as well as to our team. And we really thank all four of them from bottom of our heart. Then we have associate sponsors, Dr. Vinayak Shirsekar. He's from the Dentex, that he is from a CBCT scan that we'll be talking about, which helps us to do the analysis of the airways. So he has helped us also in a significant way. And we have two pharmas, the Torrent and the Eris. Both these pharmas, they have their special injections which are available to lose weight now, that's semaglutide. So that's the new entry to the field of weight control, and fortunately we have got these products available in India at fairly economical price, so many can take advantage. So we thank all these sponsors from bottom of our heart, and because of them this event has been possible. And let us go over the journey of this missing link. All these years we have been talking about missing link. So what is that? That is this obstructive sleep apnea, or OSA. So as initially introduced by Wangmai and Mihika, that sleep is very important to all of us. We know that we sleep for 1/3 of our life. Generally we believe that aram haram hai, isn't it? We all have been taught that aram haram hai, but aram karna zaruri bhi hai, utna hi zaruri hai, and that is necessary because the remaining 2/3 of our life will not be fruitful, will not be effective if this 1/3 part of the life is neglected. So what is sleep? If we have to define sleep, how would we do that? Sleep is a naturally reversible. See, most important thing is that we all know that we all become unconscious kind of during sleep. We are not aware what's happening, but it's a reversible unconsciousness. So it is something different from a coma, which will not be easily reversible. So this sleep is a naturally reversible state which recurs repeatedly. It is a recurring state of mind and body characterized by altered consciousness. And also we see that the sensory activity is reduced. Even if there is a little noise around, or little somebody even comes and pats us on our body, we may not understand unless the sensory input is very heavy. If there's loud noise, if somebody really hits us, then we may wake up from the sleep. But otherwise we will not realize if that happens. And if that happens, then that sleep is called light sleep. That is not a good sleep. So some लोग कोई लोग बोलते हैं कि अरे मुझे तो छोटी सी आवाज से भी हम जग जाते हैं, कोई भी बाजू में चला तो भी हम जग जाते हैं. So that is obviously not a good sleep that we will describe. There is reduced muscle activity. We can toss and turn in the bed. People turn their side, but then obviously we don't dance in the bed. So there is muscle activity is reduced. And in REM sleep that we will be introducing to you, there is something called as rapid eye movement sleep, which is important, where the eyes are moving but the full body is paralyzed. We see dreams during that phase of the sleep also, but these dreams are not enacted, and that is the arrangement of the body that we are paralyzed that time so that we are not enacting our dream. If that doesn't happen, then what will happen? That is also disaster that can happen to some people, but then otherwise we don't want it to happen. How does this happen? This sleep is under control of what? It is under control of a chemical called as adenosine. Adenosine is not a new word to us, but it's a common molecule which is there in the brain, and that helps us, in fact, sleep. And there is one substance or one favorite thing that we keep having, which is the adenosine receptor blocker. It's a quiz to you also. What is that we consume that is an adenosine receptor blocker? Anybody? Yes, somebody said caffeine. Yes, very good. That's Dr. Babita Patke. She's a gynecologist, my dear friend. And true, it is that. So, in fact, the tea coffee that we all consume is an adenosine receptor blocker. And that's why we were repeatedly announcing that have tea so that our brains remain alert and active while learning about sleep. And now, our voice. We will have mics. We have mics in the audience. Yeah. Whenever anybody wants to talk, please raise hand. We have people who can circulate mics also. Aditya, please look into that. Yeah. So it's not only under control of adenosine. So what happens is that as we get tired, the adenosine accumulates in the brain, and when there's more and more adenosine, we'll feel sleepy. Similarly, it is under control of circadian rhythm. Circadian rhythm is under control of sun, that is obviously the light and dark cycle that goes on. So the signal goes from retina, it goes to the suprachiasmatic nucleus that is in the anterior hypothalamus, and then to the pineal gland, the melatonin is secreted and all that works. So under the influence of these two major pathways, or rather chemicals, the sleep and wakefulness cycle continues. So why sleep is important? Sleep is important because it helps us to restore physically. It gives us the strength. It also cleans up the toxins in the brain. Even the dirt that is getting collected, all that is cleared in the sleep. It also helps to the processing of the memory, which is especially happening in the REM sleep, that happens in sleep. It strengthens the immune system. It regulates the mood. So there are multiple benefits of sleep. That's why sleep is important. And how it happens, as I partially mentioned to you, the sleep happens in a stage of a cycle, I would say. So the N is the non-REM and REM sleeps. So its cycle starts from the N1 stage, that is your light sleep, and the brain waves also keep on changing from the beta wave to the delta wave, the beta, theta, then you have alpha wave. So you go into deeper and deeper sleep as you move from N1 to N2 to N3, and then you go to the REM sleep. So every sleep cycle, which generally lasts for about 90 minutes, happens this way, and then we come back. So throughout the night, generally there are about 5 sleep cycles that happen, so that you get about 7.5 hours of good sleep. And as you would notice in this diagram, as we move towards the 5th cycle, the duration of the REM sleep has increased. That means we will have more dreaming happening in the early hours of the morning, early morning hours. So that's why we feel that sakali swapna padtat, that all people, why people say that subah sapne kyun zyada aate is wajah se. And there is a duration that is attributed. So N1 sleep is a very short sleep, about 5%. N2 sleep is about 50%, N3 is about 20%, and REM is about 25%. So this should be the ideal distribution. This is analyzed when we do the detailed sleep study, that is polysomnography, and this helps us know that how people are really getting sleep or no. There are some sleep hygiene, as we talk about hand hygiene and food hygiene and all that. Similarly, sleep also has some rules and regulations. We will talk about it more in detail later when we see the cases. But as to just take you through that, we should stick to the schedule. We should relax, use the bed only for relaxation, limit the screen time, avoid caffeine in the later hours of the day, exercise regularly but not at late hours, and have your room cool and dark, restful environment, and manage the stress and relax well. So if this happens, obviously this supports to have sleep better. But unfortunately, in the current era, there are a lot of causes for sleep deprivation. And there are some medical causes like narcolepsy, but which is relatively rare. But the commoner ones, I would say, are more the social causes, the work demand. My husband comes back home at 12 o'clock, and my child has to go for a school at 7 o'clock, so I have to get up at 5 o'clock in the morning, so I get only 5 hours to sleep. And when the need for sleeping is generally about 7 to 9 hours. So this is a common story of many housemakers who homemakers who are not able to sleep adequately, and then they feel I try to compensate in the afternoon, but is that enough or no? That we will learn today. Then there are shift works which goes on for doctors like us. We get phone calls at any times of the night also, even at 2 o'clock we are remembered by patients, and then we need to serve, so that sleep gets broken by that. There is other issues like some people living in chawls, especially the water supply comes at odd hour, like 3 o'clock in the morning BMC ka pani aata hai, so then they have to get up at that time and fill water. Then mosquitoes are always there around us, which keep on biting, especially the Culex mosquito cause so much irritation that people sleep get disturbed. Then issues like excess noise on the road, noise, those who are staying next to highways or crowded roads, or sometimes neon signs have big lights coming into house. So there are lots of reasons for disturbance. People stay in small rooms where there is hardly any space. The बच्चा रात में पढ़ते रहता है तो इसके लिए हमारी नींद भी डिस्टर्ब होती है. So there are hundreds of reasons which can affect sleep, and sleep is the last priority in this world right now, I feel, which is the most unfortunate thing happening to our generation right now, because we feel we want to progress, we want to move fast, we want to catch flights, we want to have our companies grow, we want to have more and more money, but in that process what we have compromised is our sleeps, and in that is been taking a big toll on all of us. So this is something that we must remember. People like this guard who's sitting is झपकियाँ ले रहा है, but वो रात की नींद भी उसकी ठीक नहीं हो रही है, and he just sitting in a slouching posture. But of all these, the most important for which we have come here to learn today is the obstructive sleep apnea. So this is a very misleading disease, or I would say a cheater, where people say कि इनको तो नींद का वरदान है, ये तो कहाँ भी सो सकते हैं. आपके सामने भी अभी क्लिनिक में भी जब आपके रूम में आने के पहले बाहर भी वो सो ही रहे थे. These type of arguments are posed when we talk to our patient कि इनको नींद की बीमारी हो सकती है. And that is a big confusion that is there कि ये नींद का वरदान ही actually incomplete नींद का एक लक्षण है. That is that your sleep quality is not good, and they are actually in fact sleep deprived. How that is, that we will describe to you. And as we are on this topic now, let's make the beginning of this important word, that is obstructive sleep apnea, which is caused by a repeated blockage of airway during the sleep. In a normal breath, how you see that the air enters your nose and it goes down through the nasopharynx and then pharynx, and then it enters the larynx, and then it will go down into the lungs. This is a smooth air passage which is happening. But unfortunately, in people having sleep apnea, their tongues are actually falling back. There are reasons for that we will explain. But then the air space here in the pharyngeal region is severely compromised, and the air is actually returning back from here. This is like a state of apnea. If it is partially blocked, then it is hypopnea. And this keeps happening repeatedly throughout the night, maybe 10 times, 50 times throughout the night this happens. And obviously, when this happens, what happens is that you are sleeping, your upper airway closes, especially because your muscles are relaxing that time, because in sleep muscles relax. And then when the upper airway closes, air is not entering in your lung. There is a deficiency of oxygen in the blood. There is a buildup of carbon dioxide in the blood. And this is sensed by the brain, and the brain considers this as a threat to the body. And for the survival purpose, the brain awakens the man or the woman from sleep. So there is an arousal, which may be a complete arousal or a micro arousal, which may not be remembered later during the day also, or after you get up. But this micro arousal then tightens the muscles, upper airway opens, the snoring stops, and the sleep is again restored, and the whole cycle repeats again. But the effect of these two things happens on the body because of hypoxia and hypercapnia. As it is perceived as a threat by the body, the fight and flight mechanism is activated, and sympathetic nervous system gets into a surge, and that increases your blood pressure, increases your heart rate, increases your cortisol, adrenaline, everything. All the stress hormones it's like a wildfire in the body that sets in, and throughout the night, multiple times. Imagine your neck is, or you're getting choked, or somebody is putting a pillow on your face repeatedly hundreds of times throughout the night. what will be the state of that person. And the sleep is fragmented repeatedly. So all those stages which I described to you, the N2, N3, REM, these stages just never come to this person. The person remains in only N1, N2 sleep throughout the night. मैं तो बाजू वालों को लग रहा था कि मैं ये तो आदमी सोया था, लेकिन वो खुद कहता है मैं तो उठा तभी मुझे लगता है मुझे और 4 घंटों की नींद की ज़रूरत है, मेरी नींद पूरी ही नहीं हुई है. So all these things are happening, and this is happening to many people all around us, and this is what is sleep apnea, and this is kind of a primer to sleep apnea. Now I would request my colleague Dr. Sharda. She's a new entrant to this field. She's a chest physician and a fellow in sleep medicine. She has done her education from MGM College, and now later on she did her studies from St. John's Hospital at Bangalore. So I would ask her to give that exact definition of, because everything has to be categorized properly so that we can call somebody having OSA or not having OSA. So I hand it over to Sharda.
Thank you, Dr. Pushkar. So everybody loves a classification, and to diagnose OSA, we need 3 criterias. Criteria 1 includes the symptomatology. Criteria B is the diagnostic testing to confirm your clinical findings. And criteria C is only the diagnostic test. So the criteria A that constitutes maximum amounts of symptoms of sleep apnea are snoring, that's the most common, choking spells at night, non-restorative sleep, breathing interruptions, insomnia, and sleeplessness. If these symptoms are present, you should highly suspect a person might have OSA. The criteria B is AHI, that is apnea hypopnea index, where apnea means cessation of breathing because of complete blockage of the airway, and hypopnea means a partial block of the airway. So if that number is more than 5, you consider that the patient is sleep apneic on a diagnostic level 1 or a level 3 PSG.
This is per hour, no? That index is per
hour. So if a level 1 study is done when you are doing it out of the center, not at home, and a level 2, 3 are done and 4 are done at home. So any of the levels, if the test is done and if the number is more than 5, then you say that the patient is sleep apneic. Or the third criteria is that even if the symptoms are not present, but a score of more than 15 is seen per hour, then we say that the patient has sleep apnea. So this criteria tells you how to get a diagnosis of a patient with obstructive sleep apnea.
So to just simplify, if I may say that, see, if you have criteria A positive and B positive, then it becomes, but if C is separately positive also, it becomes sleep apnea. So if you have less symptoms but a worse report, that is you're more than 15, then you still become sleep apneic. But if you have more symptoms and even if the AHI is just above 5, you still become sleep apneic. So just to make it easy, your number is also matters and your symptoms also matter. So symptomatology is equally important. Yeah. RDI is respiratory distress index. Yeah.
So we'll be talking about it further.
You can just give a little.
Just to prime. RDI is apneas, hypopneas, and as well as RERAs, that is respiratory event related arousal. So normally the flow in the PSG is completely sinusoidal, but if there is a flattening or a plateau at the level of the obstruction, then we call it as a RERA. So there is no desaturation or there is no oxygen levels dropping with a RERA, or there is no arousal seen. But if there is some sort of a flow limitation present, then we call it as a RERA.
There is an entity called a UARS, which we'll be introducing towards the end, but in that these RERAs are seen, where the limits, after all, apnea, hypopnea, these is what we doctors only have set some limits. So, but the body doesn't know that. So even if it is not meeting the criteria of having an hypopnea, anything less than that, but having a flow limitation, if your obstruction is there to your passage of air and there's a flow limitation, that also can cause arousal or micro arousal or a disturbance in the body. In some persons, brains are so active or rather sensitive that they get even affected by minor blockages in the air passage also, and they will still suffer like an OSA patient. So that's the criteria where RDI comes in picture and this RERA comes in picture. Now, let me tell you one interesting fact at this juncture, that if we compare ourselves with animals, our animal friends are actually more blessed in not having so much of sleep apnea. So we are having a curse rather of having sleep apnea, let me tell you. But obviously it is an evolutionary trade-off, because we have got this ability from the nature that we can speak, we can phonate, we can make different noises, sounds, and so that we can have language function especially. But in that process, the position of our larynx has gone down, it has slided down, and our pharynxes have become more flexible than the animals. Animals have a cartilaginous coating to their pharynx, so it is more protected, but our pharynx doesn't have that. So our pharynx collapses easily when we sleep at night. We tend to sleep in supine position, which is not the common position taken by animals. You may see the animals lie on the slide or they even lie prone. So that's how also they are protected. So, and we probably eat more than needed. Animals need to make lots of efforts to get their food. So we eat less. So unfortunately, we have seen that next to human beings who get sleep apnea are the dogs, are the pugs, who are fed by us and made obese like us. That's why, but an active dog who is moving around, or active lion or a tiger who is moving around will never get sleep apnea. So see, it is अपने ही किए कराए का सब हम भुगत रहे हैं जो भी है वो, but उसके ऊपर भी जो भी solutions है वही सुनने हम यहाँ आए हैं आज. So hey to get this.
So the prevalence of OSA in India, there's a recent paper that came out in January 25, which shows that around every third person in
One
the
third?
population
My goodness. Oh.
is
So आता इथे हॉल मधले
suffering.
33 लोकांना आहे म्हणजे.
So almost 30.5% have OSA, and the statistics is no different in developed countries. So, but the unfortunate part of all this is that there's no testing done.
Even in USA, just note even in US, which is considered the most powerful country in the world,
80% are undiagnosed.
80% are undiagnosed, and we are seeing the effects of that currently happening in the world.
When I want to add something here.
When you don't have good sleep, what will happen is obvious.
So today is Sunday, the topic is sleep. Tea and coffee is served here. I don't have to say the remaining things now.
Mic to the audience, please be on your toes. Yeah.
Actually, the people whom we are including in the 30.5% of the world population, they belong more to the mild case of OSA, where there's hypopnea and less than 5 events per hour, and they are also included in that 30. I may be a hypopnea, but 5 events per hour less than 5 events, or the definition actually says 1 to 14 events per hour of hypopnea and apnea is supposed to be a mild case.
So mild ones also, doctor.
Mild ones without arousal are the ones which we are missing. If I have to get up 3 times in the night, I am definitely going to go to the doctor. So people who don't get aroused are the ones whom we are missing, but they ultimately are very mild OSA. So, and they don't have much clinical implications. If you really
that's a matter of controversy.
Yes.
Let us see. But we strongly believe that milds also need to be treated, because that's how we are probably missing a big chunk by this definition of mild, moderate, severe. I think more and more. We have all gone through this cycle. The blood pressure also at one time we were accepting age minus or how much was age plus 100. Minus 100 करके कुछ BP minus 100.
Pushkar, you tell me only one thing. If I'm saying that I'm sleeping very well in the night, I don't get aroused, I am going to say I'm not OSA.
So
But I
then
may
you
be
do
an OSA, but I will still say I'm not an
हाँ,
OSA.
but then
So that's a very big chunk,
very big
very
area
big
that
chunk
is the
and very
area of
difficult
control.
to
We will
diagnose.
discuss that. I think that's
No,
there
I
in
think the
so let's
unfortunate part is that only AHI is taken as the holy grail or the only matrix that is considered. If
Yeah.
you look at other matrix like RDI, probably the numbers might
numbers
go,
will also
go up.
change. Yeah. So that's why I think we are still in that stage of
The book
learning.
is also saying up to 5 is a normal. If you have a AHI of 5, it is normally considered to
But
be.
this 5 also is a random number, let me tell you.
I don't know. I have read the
nahin,
book and I've come,
nahin,
so
that
I have
is
nothing else
that
to
is
offer.
100% right. But the same story has happened to blood sugar numbers, same story has happened to cholesterol numbers, same story has happened to blood pressure number. So things are in that stage of evolution. So we are also learning.
And just
So
to add to
let's
that,
take a case.
just to
at
add to that, a mild OSA patient can become moderate over a period of time. So that's
That is also
the reason why a
possible,
mild
yes.
OSA can be diagnosed and treated
Yes.
at an earlier age.
Yeah. So I
Completely
think to
agree.
make it more interesting, let's have a case.
Case, yes, let's start with a case. So let's consider this is like our medicine clinic and you are my professor. So it's a 50.
All professors
So
are sitting here. Yeah. Professor Dr. Shobha Deshpande, Dr. Rekha Bhatkande madam. We have Professor of Cardiovascular Thoracic Surgery sitting here, Dr. Jayant Khandekar from Sion
Hello, sir.
Hospital. So we have big Professor Dr. Mokal, who is also Professoron ka Professor. ऐसे sir हमारे सामने बैठे हुए हैं. So we have.
So let's start with a case. It's a 58-year-old gentleman, hypertensive. He unfortunately rammed his car into a tree and presented to the ER. And on further inquiry with the spouse and the patient, the spouse was very unhappy about his sleeping habits. So you would ask me, why would I be asking sleep history in the ER?
True. See, this needs that awareness. I think you are an aware doctor. That's why you asked this history. But otherwise, it would have been treated as only an accident,
Yeah.
and the person is.
I think ortho would have just
Ortho
seen
would have
and
just come, just done the necessary thing. If the injuries were minor, he would have been sent home also. खाली उसका MLC करना जरूरी है, पुलिस केस करो.
नहीं करना है.
तो बाकी वहाँ उसका कानून में वो केस दर्ज हो जाती थी, लेकिन आपने because you are an alert doctor and you are aware that this is could be the accident should not be taken lightly.
Yeah.
And that's why you asked this history, and then the history came forward.
Yes.
Yeah.
So on eliciting the history from the spouse as well as the patient, the spouse complains that he often dozes off at traffic signals. He has loud snoring which is disturbing her sleep, choking spells at night, and excessive daytime sleepiness, which are the consequences
ये
of
wife
some.
और snoring के story पे मैं एक छोटा सा बताना चाहता हूँ. My personal. They speak the truth. They are the sufferers for years together, so that they speak the truth. No, on that juncture only I was about to say. कि when
No, I was asking,
when
is there a definition of OSA with respect to these like snorings, number of snoring per night? Is there a definition?
So we'll be coming
we
to
are
the.
coming to that. But on this snoring issue, let me just share one thing. When I am asking sleep history to my patient, and I'm looking at the patient, say, Dr. Rupa is my patient, and I'm looking at her and I ask her कि आपकी नींद कैसी है? तो नींद तो हमें बहुत अच्छी है, मैं कहाँ भी सो सकता हूँ. क्या आप खराटे लेते हैं? The answer would come from Dr. Chopra. That is the wife who is sitting there. And if the answer doesn't come from here, and the answer comes from the person who is sitting next, and if the answer comes with the shortest of the span, then I know that this is a serious मामला है. ये कौन मसीहा डॉक्टर मेरे सामने बैठा है कि जिसने आज मेरे दुख को पहचाना और इतने सालों के बाद पूछा कि आप खराटे लेते हैं क्या? Because this is never considered as a symptom of a disease. ये तो पूछने की बात नहीं है, ये तो खाली हंसने की बात है या छुपाने की बात है. That's how we have been treating snoring as all these years. So कोई तो पूछे हमें कि हमारा दर्द क्या है, कैसे हमने इतने साल बिताए, इतनी रातें काटी, कैसी करवटें बदलते रहे सारी रात हम, ये कैसे? Yes, madam. Mic to madam, please.
I'd like to tell you, my grandson was 8 years old when one day he rang me up from the landline saying that, Aji, I need your advice. So I said, okay. He says, Daddy, he used to call him Dada. Daddy, in the night, he suddenly stops breathing. And then I'm scared. Ati, what to do? This kid was sleeping in their bedroom or was sleeping with him 1 or 2 nights or something. And this is what he observed. He was scared and he rang me up. And then I told my son-in-law, please go and meet,
the sleep
experts
study,
like you. Yeah. And
so the
he
sharp
is on,
observation of
he
an
is on the
8-year-old child.
Yes.
Sharp observation. Maybe he has really
See,
inherited.
we've always made fun about the spouse complaining. But see, this can actually scare family.
Scare a child also. But he has probably inherited your genes fully, so that the doctors मुलाचे पाय पाळण्यात दिसतात. At the age of 8, he diagnosed sleep apnea of his father. So that's fantastic. But that kind of alertness and awareness has to reach to the society, and people should on their own come and tell the doctors that we are observing this thing. People are just suffering and they just don't know that there is some treatment available for this issue, which is a problem to all. So sorry.
So on examination, his BP was slightly on the higher side. He was morbidly obese. He had a short neck and a thick tongue, and his neck circumference was around 44 centimeters. So what do you all think is the diagnosis?
what else? We have इतना बुलाया है, कभी खाना पीना खिलाएंगे तो और कुछ दूसरा कुछ हो सकता है. But
you want to pass us, I know that.
So let's
so
start
what is
from
the significance of age? Like how we go over a classic case, no? What is the significance of sex? What is the significance of age? That's how we are going to take the case.
So let's start from the top. So you see the dark line here. The dark line shows that as we age, the number of persons or number of people with OSA increases. That is, OSA is more prominent in the elderly population. And you see a wide gap between the male and the female ratio for age groups below 50 years. But this gap suddenly narrows down, it converges and narrows down to a ratio of 1:1. So that means that males are more predominant or are more predisposed to having OSA compared to females in the earlier age groups. But as you age and because of some hormonal changes in
obviously the protection of the estrogen progesterone that the women enjoy, that is taken away after the menopause.
Then the ratio of male is to female becomes 1. So elderly, both males and females are equally predisposed.
Yeah.
So again, these are some statistics where in the age group of 30 to 69, the stats almost 40% have OSA. In the elderly, that number jumps to 56%. And out of the 56%, only 8% are tested.
So again, the same problem that the investigation done is too less. Many cases are missed out.
So you see here that the symptoms which females come with are different from that of males.
So this is interesting to note that not men and women can have different symptoms for the same disease. So what is the difference that we see?
So the difference is that females come with a lot of psychosomatic complaints, like daytime fatigue, depression, insomnia, anxiety, nightmares, and some gastroesophageal reflux kind of symptoms. But males are more often come with those classical symptoms of witnessed apneas, heavy snoring, nocturia, and the consequences end up spilling over in the daytime, causing daytime sleepiness.
So this is the worst combination that can happen if a lady who has OSA marries a man who is also having OSA. And ये खराटे मार रहा है रात भर और उसको OSA की वजह से already insomnia है. So both are the woman is suffering more because of the noise next to her and her own air passage getting choked up. Serious matter.
So now let's come to the symptomatology and let's expand more on each of the symptoms. So habitual snoring. Habitual snoring is actually a complaint by the bed partner. And what actually happens during snoring is what we'll get to know now. So as you go into deeper stages of sleep, there is a fallback of tongue, like Dr. Pushkar told us before, and this causes fluttering of the uvula. As the uvula flutters, there is elongation of the uvula over time, and this causes constriction at the site of
The
the
length of the
airway.
uvula increases over a period
over
of months
some-
to years.
And this repetitive
Okay.
repetitiveness, that there is some constriction that is happening at the level of oropharynx, and that completely blocks your airway, causing obstructive sleep apnea symptoms, mostly apneic spells.
Oh, really?
So, could you say that you've seen that sleep apnea increases as the age increases? Could this be one of the probable reasons for
Reasons,
it?
definitely.
So with aging, anyways, your muscles become more loose also, so that the tone of the muscles is lost, your jaw also becomes, and you may put on more weight also with age. So all these factors put together, as one ages, the chances of sleep apnea increase.
So, how do you objectively say that patient is a habitual snorer, and a subjective way to say he's a habitual snorer? The objective way to say the patient is a habitual snorer is that if he's snoring 50% of the night, and a subjective way is to say that he at least snores thrice a week. And out of these OSA patients, almost 80% have OSA. So snoring is highly predominant symptom in the spectrum of the OSA symptomatology.
So if you take all OSA patients, only 80 will snore. That means what happens to the remaining?
Yeah, so 20% end up not snoring, but
Okay.
they might have other symptoms of OSA
So
as well.
OSA can happen without snoring also. That is something worth remembering. I think that's important. Yeah. Are we distributing something important, or we can keep it later? Yeah, let's not disturb the audience right now. So other symptoms can be what? Gasping for air
Gasping,
and
choking, other symptomatology like I asked before.
Madam's grandson picked up the stoppage of breath. So I think he never complained of snoring as a symptom to her, but he said the breath, shwas thambla hota. So that's what he said. So that's interesting. So we have to be alert about other symptoms also. Yeah.
So can this snoring be actually harmless? Has anybody heard of something called a sleep divorce?
That's a new thing which is coming.
Divorce caused because of sleep. That is what you're saying.
Not divorce per se, but the couple is together but living in
Okay, it is
different
not
bedrooms.
an official divorce.
It's not
Okay.
official.
Then what happens then exactly?
The couples
Two separate
stays
bedrooms.
in the other room. So that's one of the major reasons of marital discord
So
in the
both
family.
sleeping in different rooms.
Sir is talking from experience.
Yeah, so that what is primary snorers? That means? Yes, sir. It's
Can
going to
be,
come. It's going to
can.
come. Your observation is correct. Absolutely right.
So there is something called as primary snorers. So these patients keep on snoring. They are not patients per se. They are people. And those people have snoring issues, but they do not have classic symptoms of OSA like insomnia, daytime sleepiness, or sleep destruction. But their snoring gets worsened in the supine posture after having alcohol or after some nasal allergies. So the reason for the adverse effects of snoring without
so even
OSA.
if you don't have OSA and if you snore, it is still can be bad. That's what you're trying
That
to say.
is-
Yeah. So what
yes.
are those adverse effects?
One is the marital discord. Second is hearing loss, which are seen in the snorers as well as the spouse
Even the
sleeping.
spouse also can
sleeping,
get because of his noise.
Yes.
Oh my God. So it's like कोई क्या बोलता है उसके तो मुझे सिंहासारखा घोरतो असं पण बोलतात. These kind of descriptions we get from the शेर जैसे कराटे मारता है तो वो भी so that kind of loud noise continuously getting into the ears of that wife can lead
cause
to
hearing
even
loss.
hearing loss to her as well.
And there was another paper in 2008 by
Yeah,
Lee
this
et
paper I
al.
think is worth noting. Please note
that
this.
the heavy snorers, that is people who are snoring around 50% or more during the night, are shown to have atherosclerotic changes in their carotids because their carotids is near the voice box.
I mean, all of us have the artery going to the brain next to the voice box. So if there is continuous sound waves getting propagated from the
Vibrative.
voice box, the wall of the artery is getting shaken,
Shaken.
and that can develop an internal intimal
Intimal
damage,
damage
finally leading to a
to
blockage, and
blockage,
which can lead
due
to
to a
even
stroke-like
a stroke.
symptoms.
My
and
goodness. So no snoring is in that case harmless. So all snoring can be dangerous. So let's go over these snoring myths quickly. That snoring generally is considered as funny, or somebody saying that it's your body that is asking for something. But no, it is actually the body is in fact needing help. It is something that is not good to have. So there is nothing like a normal snoring. Only men snore is also a myth, because ladies also, especially after menopause, they can also snore. Snoring indicate deep sleep. Again, it's a myth, because as we have seen, it is causing blockage to our air passage, and the sleep quality is not good. There's hypoxia, hypercarbia, all that happening. Snoring is just annoying, not true, because it causes diseases like BP, heart disease, stroke, etc. Alcohol, people believe that it's a good sedative, but actually it is something which worsens your snoring and the sleep apnea. So it is not good. It will cause more harm. Only overweight snore, that is again a myth. I'm sure Dr. Samrat and Dr. Vidit will tell that people with nose issues or jaw structure issues, even if they are lean and thin, can have snoring, or rather sleep apnea also. It is only at the nose level, again a myth, because it is happening more at the throat level. We have seen the tongue is falling back. It is happening there. Home remedies can cure. Obviously, it is not that simple. Otherwise, we would not have been sitting here. And if you don't wake up in sleep, it is all right. But no, it is still damaging, because you may be having micro arousals. You don't need to actually sit up while snoring. So
Just to add to that, Dr. Pushkar,
Yeah.
that we are in this era of social media. So a lot of these Instagram influencers also talk about nasal strips and the mouth strips, which also is a big myth and misleading.
Yeah, there is very small role that the strip can play, but what is happening at the throat level, it can't really repair anyway. The only thing, it will widen your nose a little, and some obstruction at the initial part of the air passage can be reduced. So when should we really be worrying? Obviously, when the snoring is loud, when there is obvious choking, gasping happening at night, when you get up with a morning headache, or if you continue to have daytime sleepiness, it is that something you must remember. So snoring isn't just a noise, it could be your airways struggling to breathe. This is the snoring myth that we have got. I thank our adage team for sharing this slide with me. I really appreciate. आपने जो slide बहुत अच्छी बनाकर हमें भेजी थी ये, and लोगों को बहुत मददगार साबित हो रही है. And this is the message that all of us want, that we go out from this room taking with us. And we are actually distributed these pamphlets also to you. And as doctors, we request you that let us start displaying this in our clinics, that snoring is injurious to health. This is on the same tune that we have always been talking, is smoking is injurious to health. उसको ही पकड़ के this line ऊपर वाले के तरफ से दिमाग में आई थी, और हमारे जरिए आपके तरफ पहुंच रही है. And we have converted it into Hindi, that is खराटे लेना सेहत के लिए हानिकारक. This can be your DP. I have shared these pictures on our missing link group also, and please use that as your even DP also, or your status on WhatsApp, so that people at large will start seeing these words, and especially when it comes from a doctor, it is taken seriously. I wish these companies which are here, we have representation from Resmed here, maybe we'll have from other company, Philips and all also coming here. They are the big people who are making the machines. So, and even the pharmas are very strong. I have Aris team here, Shatrubhai, I can see, and even our Torrent team is here. They can take this as a social message, as a corporate social responsibility, and spread this message, put it on BST buses, put it on hoardings, put it in at railway station, wherever possible. I think this message has to go far and wide. That is the purpose of today's event, actually, that we start making our society aware about this. So car also possible. Yeah. What we have given today, have we distributed already? Yeah. So if we have it, we can show it to if any one of you. Like, Dr. Babita is showing it. See this kind of a poster. Snoring is injurious. Yeah. Or even our letterhead also can carry it. On my letterhead, I already put it about snoring. So wherever possible,
the pharma company can give stickers to us.
Yes, pharma company, please note.
Yeah, it's better than something other like pens and pencils and whatnots.
अरुणिम जी, आप भी नोट करिए.
एक डॉक्टर का स्टिकर होता है जो हम लगाते कार पे, साथ में उसके नीचे ही लिखा हो.
यस सर,
लगा दिया कार पे.
हो जाएगा इंशाल्लाह.
शुक्रिया.
So let's come back to our case now.
Excuse me,
again.
just one suggestion. When you make a sticker or whatever, instead of having all the information there, you can just put a QR code.
Yeah, that's
So
also good.
anybody scanning it can get the entire
Get the more
information in one
details
sheet.
also. Yes, that's an excellent
Thank-
idea. Yeah,
Thanks.
to be noted.
So
Thank you, Dr.
choking
Karmakar.
spells at night. Choking spells is another symptom which actually clinges to your diagnosis of OSA. So these are cessation of breathing that is more than 10 seconds is called as an apneic spell and after which a patient wakes up gasping. So that's called as choking or gasping at night. It is generally observed by the bed partner. It is a reliable indicator of sleep apnea and is often associated with oxygen desaturations and awakenings. Now let's come to the excessive daytime sleepiness, which is the consequence of all these nighttime symptoms, where patient is trying to stay awake but he can't, so he's feeling sleepy. And this happens when it's happening unintentionally. And it happens at inappropriate places, like a patient is in the meeting and suddenly he's dozing off in front of his boss, which is a very unfortunate and socially awkward phenomenon.
Situation, yeah.
But
And while
these-
driving also
so
that you
the-
already,
all-
our patient is already having the
Right.
same history. Yeah, yeah.
So the physical signs of such patients are that they have puffy eyes, drooping eyelids, they pause while talking, they repetitively yawn, and they have slowed responses. So this Epworth sleepiness scale is a screening tool for excessive daytime sleepiness. It is a simple self-administered tool, and it starts from 0 to 3. So 0 would be he never dozes off, and 3 would be there's a high chance of snoring. So I think all of you all are alert today. So I think your scores are 0. And but if the patient is excessively sleepy, then the score of more than 10 is considered positive.
These are the 8 different situations in which you have to score the probability of dosing, and if you add it up, then you get the score.
Dr. Sharda, my question here to you is that what would you term as a normal sleep time, and do you include the afternoon naps also?
That's
in
a
that?
very, very valid and a good point. So, a normal sleep time for adults, for adolescents, for babies, for elderly is all different. Let's start with infants. So, their sleep, they are excessively sleeping. So, for them, I would say a sleep of 14 to 16 hours is considered normal. For adolescents, I would say a 7 to 9 hours of sleep is normal. For adults, 5 to 6 hours is sufficient. And for elderly, again, around 5 hours is a good sleep.
Yes, yes. But then again, like quantity, the quality also,
Also
matters. So they
matters.
should have that deep sleep happening during that phase. But the afternoon
Noon
sleep,
nap. So about the afternoon sleep, there's something called as a circadian rhythm, like Dr. Pushkar told us before. So there are 2 waves in the 24-hour cycle where we are the alert at maximum times. So if you see in the morning hours, our alertness is the best. And that also happens in the early evening hours, like around 4 to 6 p.m. or 7 p.m. So these are the two peaks where your alertness is maximum. But after lunch, I think after 1 or 2 o'clock, there is a dip in your alertness. So if you sleep during that time around 30 to 40 minutes, that would be a normal nap. Apart from that, if anybody is sleeping more than that, or in entire 24-hour cycle, if the patient is sleeping more than 10 hours, including the nighttime sleep, then I would say that the patient is excessively sleepy.
hypersomnic, yeah.
So, if I eat a nice biryani and go to sleep, would you still call that as
Not for 2 hours. That is what she's saying. It should be less than 30 minutes. So check that out and then decide for yourself.
So let's all come to the examination part, which Dr. Pushkar will
So I'll take you through the examination. So this person is obviously having a high BMI. So this is obese patient with high blood pressure. She's already known hypertensive, still his BP is high, the short neck, macroglacia. And so let's go over each factors. And obesity obviously is a curse right now that we all are going through, and the body mass index has been increasing. It has been seen that at least 60% of the obese patients are OSA patients are having obesity. So there is a strong link between overweight and that, and this very obvious that your fat is even getting accumulated inside your throat or on the linings of your pharynx, and obviously that is causing compromise to your airway. So that's one factor, and plus your soft palate, everything is becoming more and more bulky as you are becoming bulky outside. So that is going to compromise the airway. What are the types of obesity? Especially if you see this type, apple type of obesity, where your tummy is big, that is not a good sign, because this is where it indicates that your cortisol level has been high in the body. It's like Cushingoid features that we have been all taught about. So if your cortisol level, and as we learned that because the nighttime sleep apnea is like a stress and you release your stress hormones, the cortisol level goes up and it ends up causing more of apple type of obesity, where your abdominal fat increases, central obesity. So that is obviously not good. And neck circumference also correlates very well with the tongue base hypertrophy. So if you have a thick and a short neck, it will be related to a thick tongue, and the laryngeal wall also will have more crowding. So if you have to ask your patient one question, कि आपकी shirt collar size क्या है आपके shirt की? If the collar size is more than 42, obviously 43 and above, then it becomes significant. And in the lady, if it is above 40, it is significant. So this is a very simple question that we can ask our patients to check whether he is likely to be having a problem. Macroglossia is what you can check by seeing the tongue. So tongue, if it is showing the crenations on the lateral border, that means the tongue is having less space in the mouth and it is getting pressed on your teeth. And that's why at the side where you have some crenation happening. And these two positions, Dr. Vidit will be showing the pictures also later, but just to make you aware that in our clinics, this is something which we can easily do. Ask the person to just open his or her mouth, and in that neutral position, if you see no space between the tongue and your soft palate, that is your Mallampatti score, that is your Friedman tongue position. If there is no space, it is indicative of a crowded throat. So it is more prone to causing OSA. And if you ask the person to say and ask the person to open mouth, and even at that stage also you have gradation in the same manner. So you need to see the pharyngeal wall clearly. If it is not seen, that means your tongue is big and your throat space is getting compromised. So using this information till now, we have a nice questionnaire which has been used again as a OSA screening tool called as Stop Bang Score. So our patient, where he fits, we will find out now what patient we are going through. So he was snoring, accepted, so we get 1 point here. He is tired in the day, obviously that's why he went and banged his car. He gets 1 point here. Observed apnea also she has seen, the lady has seen 1 point here. He's a known case of high blood pressure, 1 point here as well. His BMI is not that high, it's not 35, it is 30, so maybe he'll not get a point here. His age is 58, so he gets 1 point here. He has a neck circumference of 44, he gets 1 point here, and he's a male, so gets 1 point here again. So 7 is the score here. So he was anyways a high risk patient for OSA. So that's how we can use this as a simple tool in our clinics also to guess whether our patient could be having it. There's a good correlation between the stop bang and the probability of having OSA. So this is a good tool. As we are on the hypertension, I want you to take you through a journey, rather I would say a big gamut of various diseases to which the blood pressure is associated, or the OSA is associated with. So either it is a causative factor or an association. It may be a bidirectional association where the OSA causes the disease and the disease worsens OSA both way. Like in a stroke, if you get a stroke, if you had no even OSA before having stroke, but just because if you get a bulbar weakness and your pharyngeal wall starts collapsing, you will develop OSA after stroke. So that is like a bidirectional. So stroke can cause OSA and OSA can cause stroke. That is bidirectional. So there is a strong link between hypertension and OSA, and that is where I feel that every hypertensive, right now our guidelines are still saying that resistant hypertension you look for OSA. But we as a team, I strongly believe that even a pre-hypertensive should be also investigated for OSA. And that should become a norm after some time. That is, we strongly believe. Because why allow the person to have worse situation and then you do the test? अभी पहले ही करो ना, क्यों आप बाद में रुकना है उसके लिए? So link between OSA and hypertension established, link between depression, anxiety established. These all the references we are quoting just to show that these are all documented facts. There is a strong link between dementia and OSA. With lots of cardiovascular diseases and OSA, my friend Dr. Jayant Khandekar, who is a CVTS surgeon, he also, while in talking, said that so many of his patients who are coming for bypass surgery and all, they have underlying OSA. So heart failure, coronary artery disease, pulmonary hypertension, atrial fibrillation, stroke, you name it, and there is OSA. Diabetes, OSA, again proven fact. Vehicular accident, our patient already had that. And let me take you through other conditions like erectile dysfunction, then fatty liver, MASLD, then your osteoporosis. See, every organ is open angle glaucoma, eye condition, again linked with OSA. By the way, glaucoma is a nerve condition than more than eye condition. It's the nerve is damaged in glaucoma, that makes it actually a disease. So chronic kidney disease, female infertility, vertigo, pregnancy hypertension, and PCOS, polycystic OS. So many diseases have been linked with sleep apnea, and there's a list is never ending. Parkinson's, people who stammer, irritability, quarrels, poor interpersonal relationship, wars happening in the world. Because when there is quarrel at home, the butterfly effect causes war in the world. So to have peace in the world, we must have peace at home. That is another take-home message that we take from here. Substance use disorder. The biggest substance that we use is caffeine. We all kill our daytime sleepiness with the help of caffeine. So just sometimes we are misled. Because of tea, coffee, we are remaining alert and we don't go and tell the doctor that I have daytime sleepiness. Without tea, coffee, you first check what happens. If you are remaining alert, then we can consider it. So Epworth scale, I think we need to be modified. We should put a bottom line there. It should be without tea, coffee and nicotine. Nicotine is another thing. A simplest lady who is coming to work at your home also is a nicotine addict. She may be using masheri. So if she doesn't have to use smoking, but she is using nicotine in some form or the other, it's a brain stimulant. And दिन में निकोटीन, रात को अल्कोहल. अभी रात में सोने का है तो we need a sedative. तो ये चक्कर में पूरी दुनिया फंसी हुई है. Nicotine and alcohol, those industries are growing in a big way because we are not taking care of our sleeps, and we doctors are not spreading this message and not taking care of even ourselves sometimes. Attention deficit disorder in children, their sleep is not good. They have to go to school. School starts at 7 o'clock. Their teacher who teaches in the school has to wake up at 4:30 because he comes from Badlapur to a school which is in South Bombay. And then he's quite irritated because of his sleep is not good. Then he will scold the child. The child will get unhappy. Child unhappy means mother unhappy. Mother unhappy means she will sit up to 12 o'clock taking the studies of that child. The child will sleep at 12. Mother sleeps at 1 o'clock. Child has to get up at 6 o'clock for the 7 o'clock school. What happens to the family? Poor scholastic performance. Children, yes sir, coming to that. Failure in even physical performance. Post persons also get affected by sleep apnea. Their performances go down. In eyes, we said it is already the glaucoma, but even macular degeneration, hearing loss, tinnitus, lung, asthma, COPD, pulmonary fibrosis, all linked with sleep apnea. GERD, sir, you are saying that acidity. It is important. Pulmonary ulcer, peptic ulcer disease, IBS, IBD, all linked with sleep apnea. CKD, nephrolithiasis, nocturia. हम तो कई सालों से रात में 3 बार पेशाब के लिए उठते ही हैं. नहीं, रात में पेशाब के लिए उठना गलत है, उसकी ज़रूरत नहीं है. The kidneys are supposed to concentrate urine and you are not supposed to pass urine. At no need to do that, but it still happens. That means your sleep is getting broken, and when you wake up you feel like passing urine, or your atrial natriuretic factor is getting affected because you sleep apneic and you are making excess urine when it is not necessary. Peripheral edema, so many people come to us only with edema, but it can be sleep apnea underlying. Prostate enlargement, reproductive endocrine, loss of libido, erectile dysfunction, hypersexuality, testosterone deficiency, infertility, fetal wastage, hypothyroid, GDM. N number of diseases linked with sleep apnea. Acne, premature baldness, graying of hair, premature aging linked with sleep apnea. TM joint pain, bruxism, periodontitis affecting linked with sleep apnea. Infection proneness, including during COVID time, there was a nice study. It was shown that people who are suffering with sleep apnea suffered very badly with COVID. The severe COVIDs happened to them suffering with sleep apnea. Influenza, which is still active all the time. Cancers, again associated with sleep apnea. Hyperlipidemia. We just keep giving statins, but there may be underlying sleep apnea. And even the autoimmune disorder like SLE or RA have been linked with sleep apnea. So it's a long list, and we just need to be alert, aware, and ask our patient, आप कैसे सोते हैं, आपकी नींद कैसी है? If you don't ask this question, you will miss a big opportunity to treat our patients. So at this juncture, a most silent person on the stage gets the chance to talk that, okay, we have done all kinds of examination, weight, height, everything we check, neck circumference, but there's something much more than to that, the face, because that is the entry point of your air. प्राण वहाँ से, श्वास वहाँ से अंदर जा रहा है, तो उसमें कुछ गड़बड़ होगी तो डॉक्टर सम्राट, our maxillofacial surgeon, very dear friend of mine, attached with Bhatia as well as Rajesh Hospital, even as a visiting doctor, he goes as a surgeon, he goes to Bridge Candy. So he's a very experienced doctor in this field, and he has something good to tell us, which we can even diagnose in our clinics especially, and even get our patients operated if required at a later stage. So over to you, Samrat.
Well, thank you, Dr. Pushkar. So this is slightly different from what our physician friends have been talking about. Well, if someone comes to a clinic, we just look at someone's face. We can diagnose many things out of it. So this is just a brush through of what all we can see very easily in any of our general practitioner clinics too. Okay. Now, when you do a clinical examination of the face, there are a couple of things that we can look into. We can look into someone's face straight up, like a straight profile, side profile, then look for facial asymmetry. I'm going to come up with diagrams and photographs eventually as we proceed on through the presentation. You can do an upper jaw examination. Just tell the patient to open the mouth. You can do a quick examination. Then facial profile from the sides, very important. Straight, concave, convex, also called as class 1, class 2 and class 3 profile. Crowding of the teeth. Then scalloping of the tongue. I think briefly Dr. Pushkar had mentioned about that. Similarly, ankylosis of the jaw, inability to open the mouth, maybe due to trauma, maybe due to congenital, many other reasons for it. And any maybe previous trauma to the face. Okay. Now, if this patient comes to you, look straight up, divided into 3 equal parts. Okay? Look for symmetry. Again, look on the other side. It's a side profile, divided into 3 equal parts. Now, in this case, if you drop a line from the glabella, so can you just show that from the, in between the eyebrows. In between the eyebrows, draw a straight line down. You can see that the lower jaw is slightly set behind. This is, the patient has probably a bit of a retrognathic jaw. Could be one of the anatomical reasons if the patient may have sleep apnea because of that.
Why are we talking of jaw, right? I mean, why? What is the significance of jaw?
Okay, so jaw has many other features. So when you look at the jaw, it would also have different attachments to the tongue, to the muscles around it.
So the most important organ that is attached to the lower jaw is the tongue.
Is the tongue,
and
yes.
we are all talking about the tongue. ये ज़बान ही अपनी फिसल रही है.
Yes. Also, in the upper, if the upper jaw is slightly hypoplastic in one of our examples, you would see that the upper airway can get compromised in that. Okay. So these are all anatomical structures which are interrelated with each other. Again, just to describe over here, what you can see is a concave profile, which is class 3. Class 1 is Miss Aishwarya Rai. Rarely seen, the most beautiful, a straight profile.
Ideal.
Well, you can call it ideal, but I mean, it will change slightly If you go to different states, different places, the idealism changes slightly over here. And then we have class 2, which is most commonly seen amongst us, which is a very convex profile. If you can look at the lower jaw, it seems to be slightly set behind. This you can easily pick up in the clinic. Okay. Now, a live example of a patient. As I said, putting it into different parts, we've divided the face. If you see the lower jaw in the first photograph, so can you just show around? No. In the photograph, you would see that the lower face is slightly smaller as compared to the middle part of the face.
There's a gap here, no? This is
Yes. Same if you look at the other photo on the side, you would see a convex profile. If you would drop a straight line from the glabella onwards to that, you can see some amount of deficiency seen in the lower jaw. So this patient probably has a retrognathic profile. It's a class 2 profile.
So कल से अभी सबका चेहरा ऐसा ऐसा देखना पड़ेगा.
Yes, people start. I mean, when I started training,
in
I saw
our
observe
clinics.
faces, and people used to like, why is he observing faces?
वो बोल के we have to tell the patient before
Absolutely,
what.
absolutely.
We may be
absolutely.
misunderstood.
Yes. Again, joint ankylosis and retrognathic jaw. Now, this patient, poor patient, had a joint ankylosis. As you were talking about social aspect of children in schools, this boy felt neglected when he was going to school. He avoided going to school. He had some other features probably, but a psychosocial aspect is also equally important in these kind of patients. Okay. Now, again, hypoplastic maxilla. Why would I say? If you look at the middle third of the face over here, it is slightly flattened. So if the patient may have an hypoplastic maxilla, which may intrude on the nasopharynx or the nasal pathway, or the soft palate is slightly placed behind, can be one of the reasons for sleep apnea. I'm not saying it is always a reason, it can be one of the reasons. Okay. High arch palate. Open the mouth, see if you have a deep palate. Now, if you look at this deep palate present over here, you could also see on the sides, if you see the teeth are nicely U-shaped on top, but if you look at the sides, so can you just point out at the sides? If you see, they look to be compressed over there. So, the hypoplastic maxilla or the maxilla which has a high arch palate could also in the anterior posterior direction, but also in the sideways direction, and that needs to be picked up. Of course, you may not have the expertise to pick that up, but there is some just guess or some eyeballing can also help in this situation. Yeah. Again, overjet and overgite. Overjet is basically how your teeth are jutting out between the upper and the lower jaw, and overbite is actually the bite. How deep the bite is going in. Okay. Similarly, crowding, which is seen on the other side. You would see probably the patient is crowding, probably the bone is not enough to accommodate all the teeth. You can just tell the patient to see, occlude and check. Probably that could be one of the reasons that the jaw may have to be corrected. Now, looking at soft tissue structures, I'll just give it to my colleague, Dr. Vidit, who would be talking about this.
Vidit is also a very dynamic ENT surgeon and who is part of our team, and he is also attached to critical care hospitals, Surya, as well as visiting Dr. Dobrich Candy and having good experience with sleep apnea surgeries as well. So let's enlighten us.
Thank you, Dr. Pushkar, for your kind introduction. So coming to the nose and throat aspect of sleep apnea, we'll keep it very simple. So the airway examination begins from the nose to the hypopharynx. So as one can see in this cephalogram, the nasal cavity beyond that is the nasopharynx, where classically the adenoid structures are seen, coming to the oropharynx and then coming to the hypopharynx. So the level of obstruction could be anywhere between the tonsils, the palate or the tongue base, or even the epiglottis. Now let's assume that panic-stricken patients come to your clinical OPD with complaints of decreased hearing of their child since the past couple of months. They also complain that in the PTA meeting, the teacher mentioned that the child's grades have dropped a wee bit compared to last year. The child has snoring episodes at night. And on further probing, you ask the child's parents, they say she's bedwetting at night.
Just interrupt you at this juncture, but point to be noted by all that snoring is not at the age of only 58, it can be at the age of 8 also.
Absolutely, that's really
So
correct,
children
sir.
also can have sleep apnea, and that's something all the family physicians who also treat even young children should remember that it can.
Hello. Yeah, this is the point where we start converging the medical aspect as well as the maxillofacial and the ENT aspects of things too. Slowly and steadily, you will start observe that everything is interrelated with each other.
Yeah, sorry.
Yeah. So on further probing, you realize that the child also is bedwetting during sleep. So the clinical examination for a general physician also, what they can actually see in this child is, you will obviously see the child walk in your OPD with mouth breathing. You can see the upper crowded teeth on examination. And as my friend Dr. Samrat mentioned, that you could also at least have an eyeballing of the high arched palate. So this is classically adenoid facies. And this is a major cause of concern for obstructive sleep apnea, especially in the younger age group. Now coming to the middle age group and the elderly age group, simple clinical examination of the nose and the throat can give a lot of evidence. So there's a nasal tip raising test which is done, where you simply just raise the tip of the nose and you see the deviated nasal septum, or the lateral aspect of the nose where you see those bulky polypoidal structures, but actually they aren't polyps, they are hypertrophied inferior turbinates, classically seen in this case. Yes.
Airflow. Here.
Yeah. The other thing which one can do in the OPD, a very basic test, is take a tongue depressor, ask the patient to just breathe out through the nose and see the fogging of the air on the instrument.
Just take your tongue depressor and keep it below the nose and
Correct.
ask the patient to
so the fogging of the air on the instrument gives an idea whether there is any airway compromise, even if the nasal bone deviation is not that prominent. The mouth, the oropharynx. So we have two scales here which we are looking at. We have the Malampatti score and we have the Friedman tongue or palatal position grading. Clearly evident in the Malampatti score, most of us are aware that you ask the patient to take his tongue out and say ah, or just protrude the tongue out. Class 1 is a complete visibility of the soft palate, and as you go towards class 3 and class 4, the tongue only is seen and the soft palate starts getting obscured or masked. Again, there is clinical evidence suggesting that higher grades of Malampatti score leads to a severity of obstructive sleep apnea. The Friedman tongue classification is more or less similar to the Malampatti score. The only difference between the two is that in the Friedman tongue classification, the tongue is inside the jaw and it's in the neutral position. So the patient doesn't have to protrude the tongue out and say ah in this. Lastly, coming to a very significant step, especially for our younger age group and the adolescent age group, is the Friedman tonsil size grading. So as we discussed the adenoid facies and evidence of adenoids in the nasopharynx of the child, the other thing which we look at is the tonsils in the oropharynx. There are 4 classic grades of tonsils which we see. The grade 1 is the tonsils hidden in the pillars. Grade 2 where the tonsils are just coming outside the tonsillar fossa. Grade 3 almost coming to the midline. And grade 4 classically which we are aware of as the kissing tonsils. So just to understand that any child who is going to undergo an adenoidectomy, the surgery to treat sleep apnea, the tonsils also need to be addressed because they also are causing the oropharyngeal compromise. So the surgery is done 2 in 1. The adenoids and tonsils are removed in the same sitting. Yep. I'll hand it over to my friend Dr. Sharda
Dr.
again.
Vidit, I just want to ask you one
Yeah.
small question.
Yes.
Suppose your Malampatti score is high, but
Sorry, sir, I didn't get you.
if your Malampatti score is high in
Correct.
a child,
Okay.
and the child actually has nasal breathe, we all breathe through the nose in the sleep. So if his turbinates are not hypertrophied, he's breathing through the nose, but he's got a Malampati score where the palate and soft palate and tongues are very close.
Correct.
But still he may not be an OSA. But would you still give him attention?
Would you still give him a-
Would you still give him
Attention will you give or
attention
no?
that you need to be treated?
So we
No,
will.
he is not OSA. He's breathing through the nose. He's got no hypertrophied turbinates. A nasal examination
But
looks
air
quite
has,
good.
air has entered the nose, but it has to cross the throat also, no? Before
Yeah,
it
but
enters it.
this
So
palate, soft palate and the tongue are in the anterior. The oropharynx is open.
see, when they are
So
not,
that,
the
that
space is not
unless the
seen,
tongue is protruding backwards.
Huh,
so
so-
the posterior part of the tongue is oropharynx, which is patent.
which may
If
not,
that's
but,
patent, then there is no
but it may
question
be
of OSA.
compromised. See, when you see high grade Mallampatti, that means your tongue is big and it is likely to be falling back into the throat when you
We
sleep.
accept that, but that's in the elderly. If the tone is not good. But what about the child? That's what I want to know from you.
So what I would do in such a case is obviously we ask the child's parents if there is any symptomatology in his clinical profile.
Exactly. That's what I want to ask.
Correct. And in case there is symptomatology where he's having occasional snoring episodes at night, despite not having a nasal bone deviation, or even the adenoids being mildly enlarged only, the second investigation I would do in this child is a CBCT. CBCT will give me a very good analysis of the volume of the airway, which we'll be discussing in the slides further, and possibly a level 3 PSG also, the sleep study in the child. Because we are trying to see that his quality of life is not compromised when he's going to become in that middle age group or cross 50 years. So we'll discuss that further once we discuss. I think your
I
point
just
will be
want to
answered.
add in, to diagnose any sleep disorder, you need three things. First is the symptomatology at night. Second is the symptomatology in the morning. And third is the consequences of these symptoms. So if the patient comes with symptoms at night saying the patient is having gasping, having some snoring present, then it is a sleep issue. If the patient is only coming with nasal obstruction or nasal symptoms, then it is an ENT issue.
No, I am more in the context of the young child because they don't complain. That's point number one.
I mean, the parents
Yeah,
are
and
saying-
secondly,
will be indirect.
I'll tell you in my practice, I've seen children with such large tonsils that I sometimes wonder how they're eating, how they're swallowing. But they say, "हमको कोई problem नहीं है." The child is eating well and all. But when you see the tonsil grading like this, then you start thinking, should I tell them to go to Dr. Vidit? कि कहीं OSA बाद में तो नहीं होगा, या should I wait for some time for the tonsils to regress by itself?
Correct. So that's where we would prefer that you convincing the parents and sending it to the specialist will make a difference because they are your first point of contact.
I think if we have to take a message from this, if the child has no symptoms,
Yeah.
then don't do anything. Probably why do
Exactly.
anything?
Yeah, correct.
Exactly. Even with that
even with-
Malampatti score being high in the
Correct.
child, but he's sleeping well.
Even
Yeah,
with
he's not
DNA,
snoring.
even
When you
with
don't know,
deviated
so
nasal
no
septum
intervention
also,
if the child is
people live with
asymptomatic is
DNS.
what the takeaway is.
People
It's
can
exactly
people
what
can
I'm-
live with DNS without having any problem. Also. It's
exactly
not that
correct.
every
You don't need
thing
to
that
treat-
is seen it has to be corrected. It is not. But
And
if you
Dr.
have-
Taude, I've seen many patients with retrognathia, adolescent, even they have no complaints. And even for that matter, acromegaly also. Some people have acromegaly, but
prognathisms.
Hello. Yeah. So again, well pointed. That's why I use the word maybe. Yes, a very important precondition is maybe. Would that treatment provide me with any additional benefit in relation to sleep apnea? One, aesthetic facial balance and all is a secondary condition, and we are not discussing that today. It's a completely a different realm. So that word maybe or a preconditional is very, very important. It has to be evaluated properly.
Every structural abnormality
May
may
not
not
require
correlate with sleep
requirement.
apnea. So if there is no sleep
Symptoms,
apnea,
correct.
there is no need to do all this.
From sleep apnea point
Ah.
of view, if he has
See, the
any
whole
other concerns
story
regarding
has
that,
started with
so
story has
my
started
point
with-
of view is very clear.
Yeah.
If I see a boy, he showed a boy who had a double neck sort
Correct.
of a picture, right? And he had retrognathia. Now I was worried that this boy, even I have done his polysomnography, and he is normal at that point,
Then
at this
don't
point
do
of
anything.
time.
Then don't do it.
Don't do anything.
Now
let's see
I'm
the
considering his
polysomnography.
adult growth.
yeah, I will.
That is where I
discuss-
want to know your
I
point
will
of.
take your point when I have an proper slide for you why these things matter at a later stage. I'll tell you the
Let's go over the diagnosis. Then
Correct.
These things will
He may
become
become.
clearer to the others who are also listening. Let's see the diagnosis.
So the takeaway here is no intervention till the patient becomes symptomatic. Yeah.
That's the takeaway. Yeah.
So let's come to the diagnosis of sleep apnea. So diagnosis of sleep apnea can be done at two places. One is at the center where you need a level 1 sleep lab, or level 3 that
So
is
this
done
is
at
level
home.
3,
So
right.
this is a level 3 image where you need at least 3 to 4 channels. First is the oximetry, the pulse ox which we are using. Second is the chest belt to know your respiratory effort. And third is the nasal pressure transducer, which tells you about your apneic spells.
All these are connected to the central processor or recorder, I would
Recorder.
say, and that finally the data is analyzed.
Next.
Yeah.
So this is a level 1 polysomnography where at least 7 channels are required to diagnose a patient with OSA. It starts from the brain and it ends with the toes. So there is EEG, there is eye electrodes present, there is chin electrode, that is EMG present. Then there are chest leads to know your ECG, your respiratory effort belts, your pulse oximetry, and even the anterior tibialis muscle is used to know if there is any movement at the level of leg or any leg movement seen with the use of EMG. So to diagnose a patient with OSA, we say that if the range is above 5 to 30, patient 5 or more, so if it is less than 5, you consider it as normal. 5 to 15 is mild, 15 to 30 is moderate, and more than 30 events per hour is considered as severe OSA. So home sleep apnea testing is most widely used. It is the most convenient and available diagnostic test, which reduces a lot of out-center patients where there is no queuing up that happens at level 1 sleep study. So level 3 is the most convenient and cost-effective diagnostic test available. The American Academy of Sleep Medicine recommends at least a level 3 study to be done at home at the minimum. And there is something called as a PAT or peripheral arterial tonometry, which is a newer version of the home sleep apnea testing, which is also called as the night owl or one night study. So it basically is in form of a ring where the vascular changes that occur after apnea are detected. So if there is a peripheral vasoconstriction that is happening at the level of vascular bed due to the apneic spells, those are converted into something called as a photoplethysmography, and those record the apneic events that occur along with something called as a actigraphy to know any moments are present during the night. So if the moments are present, the patient is considered as awake. If there are no moments at all, then the patient is considered as asleep.
Similar technology is used in the smart watches also, but the most of the smart watches do not tell us about sleep apnea directly, but the latest ones from a few companies have been even started giving the warning of sleep apnea. So that is important. So slow and steadily the studies are going to become simpler, because even the level 3 study that is done at home, but even the belt and the nose thing, some patients, when I describe it to my patients before doing the test, this is all will be hooked onto you or attached to your body. They say, "ये सब लगा के हमें नींद कैसे आएगी?" That is their first question that they say. So then we have to convince. But when it comes to as simple as putting a small pad on your finger when the PAT study is done, that is that night owl study is done. Unfortunately, ResMed, there is a Vikas, there is a good need for this one night study that you have to launch it as early as possible. It has been off market for some time, but now if it comes, there will be many prescribers to your device here. But that is how the investigation of sleep apnea will become easier and easier as the technology is becoming stronger. But when should HSAT be avoided? Yeah.
So HSAT should be avoided in any patients with cardiopulmonary diseases like heart failure, coronary artery diseases, arrhythmias, or any pulmonary diseases like ILD, COPD, asthma, which is uncontrolled, any prior stroke, neuromuscular disorders, or any sleep disorders apart from OSA.
So this should be avoided because you may get false information, like incorrect or incomplete information. That's why we need to do a detailed study in form of level 1 study.
And other channels also pick up other things which are not going to be seen
so level
by
3
level
is
3.
like a screening tool, but level 1 is the most authenticated or most
gold standard of diagnostics. So this is a level 3 report where this patient was analyzed. The case we
is
started
our patient
with.
who underwent this study actually, that 58-year-old gentleman. So his AHI came to be 26.
And that was in the moderate range with oxygen desaturation of around 79%.
So this is one concept I think we have not introduced to our audience. So can you elaborate a little more on ODI?
So oxygen desaturation index is number of times his oxygen is desaturating from the baseline by 3 or 4%. So if the baseline saturation is 97, for example, and if if his reduction is more than 3 or 4%, and that will tell you the oxygen desaturation index per hour, and
that will be noted as one desaturation, and the number of times such desaturation happen throughout the night are counted, and number of hours the evaluation happened. The evaluation period comes here. So this is the evaluation period for SpO2. This is the evaluation period for your flow limitation. That is the nasal cannula. The nasal cannula will pick up this evaluation. The finger pulse oximeter will pick this evaluation. It will give these numbers. So the lowest saturation also is important. And this saturation graph, if you will see, it is so scary. This line actually should be almost like a flat line, but it is dipping like this. And especially in the early morning hours, if you see that there are huge this desaturation happening.
And it correlates with the apneic events as well as the pulse rate variability and the desaturation. So if you see that these are the events that occur, these are the obstructive events. Along with that, this is the pulse rate variability. Like Sir said, it should be in a straight line, and there is associate desaturations that are occurring. So this is like a clinical correlation which tells you that
so all
this
these
patient
are channels
is
in the real time, and the channels tell us that this is what has happened. This obstruction is a causative effect for the low saturation. Yeah. So this report, I think most of us can learn to even understand and read, so that we can help our patient with the help of that.
So now we have established our diagnosis that this is a case of moderate sleep apnea.
Because the AHI was
26.1.
So it fell in that range. That's why we have labeled it as moderate sleep apnea. So apart from this, what studies we have done, now the patient is obviously going to go for treatment, that we have diagnosed him. But are we satisfied with only these many investigations, or we should do something more? Let us learn from Dr. Samrat.
Yes, thank you, Dr. Pushkar. Now, the science is evolving it to have even more better and accurate assessment tools. We have certain diagnostic and assessment tools, especially good for surgical interventions or to check if there are any structural abnormalities which may be one of the reasons for sleep apnea. May not be necessarily all the cases, but yes, that has to be prudent clinician judging into that. Okay. So we have something called as a CT scan, that is cone beam CT scan. We have Dr. Vinayak, who's just come as one of our partners who does CT scan for us. So it's a cone beam CT scan. You can have a word with him at some stage later on. How does it help and all? He can explain you that in detail. Then we can do a CT scan with a volumetric analysis of the airway. We can look at the airway.
Just to put our audience in the perspective, like these tests we are definitely are available, but should every patient of OSA undergo these tests, or they will be selected people only where we should do?
Again, very gray areas that you're talking about. Not all patients may require the CT scans, because as we are discussing these cases as we go on, There could be few cases which may not require a CBCT
But maybe
scan
on
alone.
examination, if you find that the maxilla is hypoplastic, and it can be in an adult also. It's not
Yes.
that the maxillary hypoplasia or the retrognathia need not be only in a child. Obviously, that person will grow one day, and so even at the age of 50, if your clinical examination makes you suspect that this person may be having a bony compromise or a soft tissue compromise which is causing obstruction to the airway, before we treat the patient with any further treatment, we should investigate. And that is where the role of our colleagues come in picture, that the dentist or the ENT
Maxillofacials
doctors.
and dentist and So the CBCT scan, as I said, we can also have something as a lateral cephalogram. I'll have a diagram of that. That has been more commonly used before, and the CBCT is a relatively advanced version of that. Then we have a virtual surgical planning. Now we use softwares to plan our surgeries or pre-plan to see what all changes that we can probably project, like a projection planning. We can also make something called as a stereolithographic models. Now this is a very patient-specific stereolithograph model of one of my patients, not related to sleep apnea, some other case, but we actually get a real-time image of the skeleton or the model of the skeleton as for the patient, so that I can plan my surgeries better. And it also helps in telling the patient that what all changes can be anticipated by him and by us.
So CBCT scan you do, and you can make this full model out of that?
Absolutely, we can make models out of the CBCT scans. We can do the virtual surgical planning with CBCT scan. We
this
can
has
do
not
many
come
other
from
things.
any grave. It is made in by
Absolutely, this is patient specific. About DICE and nasal endoscopy, I believe that Dr. Vidit would be in a better position to talk about that at some stage. Now, looking at this is a lateral cephalogram. I've just given the diagram. We've discussed this diagram before, showing us the different areas or areas of concerns. This is cephalometric analysis. This helps us. This was the go-to thing for all maxillofacial surgeons who are doing orthodontic or jaw surgeries. Of course, it's still valid, though other modalities are also helping us at this point of time. This helps us in the movement of the jaw, the angulation of the jaw, the backward and the forward movement of the jaw, the impaction of the jaw. So we can actually do some projection planning with certain measurements to see what all changes that can be anticipated in the patient. Now, again, CBCT scan, thanks to Dr. Vinayak again. So we could see, right now I can do the analysis of the airway to check how is the airway in the given patient once I have a CBCT scan. So if I refer my patient for a CBCT scan and tell them to do it for the head and neck region to assess the airway, they can give me this wonderful information that we have. Can you play the video, sir? So this is a beautiful extraction of the airway, just came out of a CBCT scan, and we can actually check what is the available airway that we have. This is where the technology is advancing to right now.
It's available everywhere.
Sorry?
It's available everywhere.
Yes. You can. There's Dr. Vinayak also is available. I think you had gone out then. Dr. Vinayak is into the CBCT aspect of things. Yeah. Now we also have where I can give you the areas of we've done the volumetric analysis. Now this is the perimeter area that I can check into. We can also check what is the length of the airway and the breadth or the width of the airway too in this region at different places.
And just to add to this, the CBCT also will give us a rough idea of the paranasal sinuses, the coronal sections of the nasal bone deviation, and the turbinates. So separately doing a CT-PNS also will not be required in a patient where a CBCT is done when you're suspecting sleep apnea.
Now, in this case, yes. Yes, you can see uvula which is quite thick, probably impinging on the airway behind over there. This helps us in planning without doubt. And it also can help us in evaluation. Once we've done probably any procedures or anything on this patient, post-operatively, maybe 6 months, 1 year down the line, we can actually have a look at what changes we've done.
So here with the retropnea, you will still see the airways very well. So you know whether you should be operating or not operating.
No, there are many other factors with that, sir. So if you're talking from OSA point of view, retrognathia is just one of those points that I'm talking about. So retrognathia can have other issues also. Patient may have other
Cosmetic
issues also. Exactly. Not necessarily cosmetic, even functional, bite and all those issues. So if I keep on discussing that, it actually sidetracks the entire aspect of OSA at this point of time.
With it, no, you are taking.
Yeah. Sorry, doctor had a.
Yeah. Now my question was, whenever you do CBCT, patient is in standing position, and you want to diagnose obstructive sleep apnea in sleeping position, supine position.
Again, we had the same question over there. So best person to answer would be Dr. Vinayak, who does the CBCT scan for us. We are trying to figure out, can we do it in the sleeping position, or if you're doing it in standing position as a kind of base benchmark that we have, like, this is because we can just do it in a sitting position.
The bones may not change.
The bone structure doesn't change.
Even
the soft tissue
standing,
structures will change.
Soft tissue may
Soft-
fall back or whatever.
Yeah, but sleeping position, the soft tissue is in a different position, and standing position, the soft tissue is in a different position. So how accurate is that sleep, the obstructive?
Again, as I said, an adjuvant tool. It is not the only tool that we have.
No,
Please understand. I'm not saying that it is
see,
the
I am not talking
panacea.
about
Dr.
which
Vinayak, you
exient
want
or
to say
not,
something on
not
this?
exient. I am talking about the accuracy
Please
of that,
sit
because the
come in front.
entire position of that airway changes in the position when you are standing and sleeping.
I'd like to add up a point to that. So there is, what we do is DICE, that's drug-induced sleep endoscopy. So with a CBCT or DICE will give a better clarity of the airway compromise for sure.
So static and dynamic, that is what we are coming to. The levels of obstruction can be static as well as dynamic. So dynamicity, Dr. Vidit will check. The static bone problems, Dr. Samrat will assess. And putting all that together. Vinayak, can
Yeah,
you?
like sir said, there are two things, static and dynamic. But in a standing position also, now we can ask the patient to sit on a chair, a long chair, and ask just to rest it behind. So it is as good as he is in a sleeping position, and then we can take a CBCT scan. Also, now we have CBCT scans which are in sleeping position as well. They are not available everywhere, but we have one which would be coming in Worli, but it is for veterinary purpose. But it's a CBCT only, which it's the same machine, same technology. We have that also, but then we can make the patient sit on a long chair and give him a rest over there, so that it is as good as we are in a sleeping position. So it is very close to the sleeping position, which we can get with the conventional CBCT machine as well. As the machine can go up and down, so we can make the patient sit and then take the scan.
Vidit, can we move ahead because there are many more slides to take? Yeah. So we hope that the science and technology takes us closer to that. It may not be perfect at this juncture. It may happen after some years. So
Yes,
your
that is what,
point
as close
point
we
is
can
well
get, we
taken.
can do.
The point is extremely valid, and we should be able to actually virtually replicate what is happening. Even the person is not sleeping, so that's why in fact we need to even make the person sleep. So we give sleep dosage, injections to induce sleep and do the study, because that is the actual time when the person is suffering. That is what DICE is all about. But DICE is doing an endoscopy, but we can do even CBCT under a dose of sedative. That
Correct.
may be
You
also
can do
Yes,
that also.
those machines are there where patient can sleep and do the CBCT scan. Newtom. We have Planmeca, we have Sirona, and we have Dabi Atlante. And the one which is the sleeping, that is Planmeca as well as Newtom.
So coming to the next aspect of investigating the same patient. So we have a summary of the levels of obstruction from the nose to the hypopharynx. There is a static or an immobile level of obstruction where while walking, talking, eating, they won't really move. That is the nose, the nasal bone deviation, the septum, the turbinate hypertrophy. And coming to the dynamic level of obstruction, where we have the soft palate, the tonsils, the tongue, and the lateral pharynx. So just for your understanding, this is the VOTE classification for a DICE. DICE is drug-induced sleep endoscopy. The VOTE classification is V is for velum or the soft palate, O is oropharynx, T is the tongue base, and E is the epiglottis. The indications for DICE are very clear-cut. DICE is used for surgical planning. DICE also is used to select patients for hypoglossal nerve stimulation. Most patients who are intolerant to CPAP, DICE is a very, very gold standard of investigation. And lastly is your clinical mismatch between the polysomnographic findings and your clinical findings. So if a patient is having multi-level obstruction, which you're seeing on clinical examination, but the sleep study is showing a different picture, this is where DICE plays a very good role. Can you play the video, please? So this is a classic DICE video of a patient who's having obstruction at the velum or the soft palate. So one can classically see that the obstruction is anteroposterior, which is front and back, and that helps us to plan our surgery in the right direction. Under sedation. Yeah, the next video is of the oropharynx or the lateral pharyngeal wall collapse, where the collapse is more laterally or sideways. So we know that the oropharynx or possibly the base of the tongue is the reason for the obstruction. So as this slide clearly mentions, your AP obstruction or your front and back obstruction is to do with the velum and the oropharynx. Your lateral obstruction or the posterior lateral obstruction is to do with the tongue base. And a concentric, a total circular obstruction is to do with your oropharynx, the tongue base and the epiglottis. Coming back to the video, can we show the tongue base obstruction, please? Yeah, that's the tongue base obstruction, the posterolateral pharyngeal wall collapse, which helps us to plan the surgery better for the patient. I'll hand it over back to Dr. Pushkar for the management aspect.
Yeah, so now we have diagnosed the patient fairly in detail, and now we have to go over the management. So the management of sleep apnea obviously lies on the basic fundamental principles very much before we jump on to going to any instruments or any surgeries. So as we know, obesity is playing a big role in the management of, in the causation of OSA. So obviously if we reduce the weight, there is going to be a significant benefit. So lifestyle changes include weight reduction, regular physical exercise, including yoga pranayam, meditation, chanting, because obviously your mind also plays a big role as far as your sleep is concerned. So your cooling down of mind also helps to give you better quality sleep. So it's a all level holistic approach that is important. Myofunctional exercises, inspiratory muscle training and the sleep hygiene. So let's go over all these points one by one. So if we have to reduce weight, why reduce weight? Let us see the last slide plus the pointer. That around 10% weight loss can predict a moderate improvement in the OSA. It does decrease AHI. So this the study has shown. So how to lose weight? We have to have disciplined diet. So I personally believe that to discipline diet, there is nothing like having only 2 meals in a day, because that puts a condition on your eating. Once you have pledged to yourself that you will have only 2 meals in a day, that the desire to eat or intermittently in between the meals definitely goes down. Having an unnecessary tea or a cup of tea or coffee, when that goes along with that, some biscuits will go in. So all these things can be avoided if you have pledged to yourself that you will have a brunch and an early dinner, if that is possible. So I try to recommend my patients to do that, and also simultaneously look into the vitamins as well as the mineral deficiencies and correct them. So we have one expert in the field, fortunately in the audience, my good friend Ms. Ila Pathak. She is a nutritionist and she strongly is a proponent of plant-based therapies. Can somebody give mic to Ila ji? And I have a question for her, that how would you, what would be your lookout on this point that I made just now about discipline in eating and how to control your food intake basically?
Confirming to what Dr. Pushkar said, the genetic makeup which we have today is around 3 million years old when we were Paleolithic beings and we were hunters and gatherers. Around 1200 years ago, when agriculture started happening, our food changed. And recently, some 300 years ago, when the industrialization started, our food has completely changed. So, what do you think our body will react hormonally and uh, uh, hormonally to how the food has changed in all these years?
Basically, our
It is
genes are of our ancestors
yes,
only.
yes.
And we
Genetically,
are
we haven't
behaving in a
changed,
much different way. Yeah.
but the diet or the food which we are eating is completely changed. So our body is totally confused. And what has happened is that we are overfed. As a society, we are overfed yet malnourished. So we are actually eating 3 full meals and snacking throughout the day. Okay, so basically 3 functions are happening in our body, which actually follow 8-hour cycle, which is digestion, assimilation and absorption, and elimination. So this is as per the circadian rhythm, as doctor mentioned. Uh, these processes basically follow an 8-hour cycle. So noon till 8 p.m. is a good time when our digestive fire is at the peak and we should be eating our meals. Then 8 p.m. to 4 p.m. is when the body is actually absorbing all the nutrients that have been broken down from the food, and this is the time when we should be resting, because the body is at its work at this time. It is actually building new cells and tissues, and 4 a.m. onwards is when the body eliminates whatever debris or whatever waste products that are not needed. What we are doing today is we don't follow our circadian rhythm. We are probably eating late in the night when we definitely should not, and yeah, we don't even sleep on time. So, good, yeah,
So
correct.
take home
Since
is
we are
to
awake
have-
at night, we are not getting enough sleep and we are snacking. So, simple secret to weight reduction, to getting good energy levels and keeping general lifestyle disorders at bay is following the circadian rhythm.
Yeah. So obviously, exercise in all possible form supplements this kind of a diet regime. So once both the things together, you may walk, jog, run, swim, climb, skip, dance, cycle, play, whatever possible. But physically, we need to be active. Without physical activity, it is not possible. I still remember our dean from Shushrush Hospital. She had put up a board next to the staircases. Climbing is good for health, and I have taken that message from her. Try to climb the staircases as many or as regularly as possible. So climbing is good exercise. Surya Namaskar, Yoga Pranayam, and even Jalaniti. My friend Dr. Vidit will agree that keeping your nasal passages clean obviously will improve your breathing. Coming to pharmacotherapy, that is important because now we have this nice medication available. So when should the medicine be used? If your BMI is above 30, definitely it is indicated. The medicines are in form of even the injection, tirzepatide and semaglutide that you are aware. These are injections which have been available in world, but now in India they are available at a lower cost because multiple companies have launched it. So, but BMI of 27 to 29 also we can indicate, especially if there are weight-related coexisting condition. The most important being the OSA, even the diabetes, osteoarthritis, fatty liver. So, if that is indicated, we can do. If you are not able to achieve weight loss, in spite of having a lifestyle modification, it is still recommended because it gives like a kickstart. Somebody who is trying to do lifestyle but not happening. So, if you just control your hunger by using this medicine, it helps. And some people regain weight in spite after doing lifestyle. Those who need the metabolic risk reduction like diabetes or a fatty liver, or before a bariatric surgery, weight regain after bariatric surgery, or if especially the patient wants to lose weight. So there are n number of indications possible. The drugs which we know are semaglutide. It is a drug which is resistant to the DPP4 enzyme. That's why it has a long half-life, and we can use it once a week only. So that's a big advantage. We can use once a week, and it mimics the action of natural GLP-1. It causes glucose-dependent release of insulin. Hence, there is almost no risk of hypoglycemia. And it suppresses glucagon, slows gastric emptying, gives satiety, reduces appetite, improves blood sugar, promotes weight loss, and even reduces the major adverse cardiac event, that is MACE, and also offers renal protection. That is the advantage of semaglutide that we have. We also have tirzepatide, which is a dual receptor agonist. So it gives better improved insulin sensitivity and also suppresses glucagon, as we said earlier. It has superior efficacy in lowering HbA1c and promoting weight loss, which is 47% greater compared to GLP-1. But it does come with a higher price tag. So if somebody wants to, the companies have come with injections which can be used as a throwaway injection, also use and throw, or there are some injection available which can be for a little long term. We have two sponsors today from the pharma side. You can go and see the injection. They're very easy to operate, and the cost of therapy in a month, it has almost come down to, at the outset, it can be as low as even 800 rupees, depending on what you use. So the costs have significantly come down, and that's the advantage, and we can offer it to even our middle class patients to make a beginning and make them lose weight. So that's an interesting development as far as obesity is concerned. And obviously bariatric surgery also holds true, but maybe the need for bariatric will go down. Let us hear a little more about that from Dr. Sharada.
So bariatric surgery is indicated for patients who are super obese, that is, they have a BMI of 37.5 or more, or they have some comorbidity associated with obesity like diabetes, osteoarthritis, OSA. And so such BMI is, such a patients have BMI of around 32.5 and above. And as bariatric surgery has known to control your diabetes levels as well, it is useful in patients who have uncontrolled diabetes or failed some medical management. So the range of BMI is in the range of 27.5 to 32.5. So various bariatric surgeries are currently available. The most commonly done is the Roux and Y gastric bypass, followed by vertical sleeve gastrectomy and adjustable gastric band. So these are various types of restrictive come malabsorptive gastric bariatric surgeries. So the maximum weight loss, if you see from
the comparison of all
the different
therapies.
So the maximum weight loss is seen with bariatric surgeries, which is 30% of 30% in the bariatric population, the people who undergo bariatric surgery. That gap is actually getting narrowed by using the GLP-1 receptor agonists, like Sir said, semaglutide and tirzepatide. And this again is followed by some around the range of 3 to 20% weight loss is shown by standard behavioral therapy or intermittent fasting and other exercise and other modalities.
Yeah. So weight loss obviously is very important. Now let's go beyond that. Now as we know, the tongue is playing a big role as far as the OSA is concerned. And these are some special exercises which we can recommend our patients to do, called as myofunctional exercises. So they are simple ones anybody can do, especially the way the children mock at each other. If you do that, that is almost what these exercises are about. Say you ask the person to protrude the tongue. This is all. बच्चे ऐसा सब करते रहते हैं. बच्चों को हम बोलते हैं ऐसा मत करो, वो बड़ों को ये करने की जरूरत आ गई. Because that is how your tongue becomes strong. We push your tongue on the cheek, on both sides, puff your cheek, lips. So all these areas have to be exercised. And even if you see the various mudras in the yoga, which is Brahma Mudra, Sinha Mudra, they are all related to that. So our sages had somehow already observed it so closely that when you do these kind of different exercises, your health improves. And with that, all these different asanas, the yoga practices have evolved, and they have stood the test of time. Even till today, we are doing it. So that's the importance of continuing this lifestyle. So myofunctional exercises are important to be taught to our patients. There are videos available on the YouTube which you can recommend to your patients to watch. Then this simple exercise which we recommend to our patients, we ourselves can do to strengthen our diaphragm and our lungs. So this is you have to suck in the tube here and the balls will jump inside, and you should be able to hold it as long as possible. That shows your strength. You can even blow, the blowing instruments are also good, even the flute, and there is a didgeridoo, that is a big instrument that is recommended as a therapy for even OSA, or even saxophone. One of my friends who has a sleep apnea, he is playing saxophone also using CPAP, but has significantly improved. So all these therapies are useful. We spoke a little about sleep hygiene. So when we treat a patient, we have to also counsel them on sleep hygiene. So the sleep should be about 7 to 9 hours. The bedtime and the awakening time should be regular. Bedroom should be dark and quiet, comfortable temperature. Do not sleep more than half an hour during the day. No alcohol, it actually worsens OSA. Avoid caffeinated beverages after 12 noon because it will affect the sleep. Do not smoke. Obviously, nicotine will affect your sleep. Then do not exercise within 3 hours of bedtime because you get overexcited and your adrenaline or adrenaline levels go up. Use the bedroom nothing other than sleep and your intimacy. Do not watch TV sitting in the room. Do not solve crossword or any brain stimulating activity. Don't do financial calculation, heated discussions 1 or 2 hours before sleep. And if you are still unable to get sleep when you are in the bed, do not keep on tossing and turning in the bed. Get out of the bed, read a light book or listen to instrumental music till you feel sleepy and then go back. But definitely don't watch screen. Like you people just get up and start looking at their mobile phones or put on the TV. That is not the solution for getting sleep. So this hygiene has to be followed, and then only the whole therapy becomes effective. And now we'll come to the PAP devices. This is the invention that happened by Professor C. Sullivan. And in 1981, it was recommended in the paper which came in Lancet. So this treatment is not that old, but not very recent also. So it is a treatment which is there for some time. How it works is that the mask that we showed here is actually put on either your nose or face, and it blows air into your air passage. And now here it is showing the obstructive apnea, where the soft palate and uvula is going and touching back into, or your tongue is also pushing back and it is compromising the space. When you put on the CPAP, the air which is blowing, it is at a positive pressure and it keeps the air passage open. This acts like a pneumatic splint. It's like a air splint which maintains the upper airway pattern, and it has been considered the most effective non-invasive therapy till now. So this is very important. We have devices brought here by our colleagues, and you are most welcome to go and see those devices, at least handle the devices, because there are myths about CPAP. I will be asking Dr. Sharda to take over the further information about CPAP from here on. But you all go and then later see the devices, feel the mask also as they are available with them, because the myths first should be broken by the doctors, and then only we can confidently tell our patient. Many patients भी वो तो बहुत बड़ी चीज होगी, इतना बड़ा मशीन हम कैसे लेके जाएंगे? Can we go with the machine outside Mumbai? Is it portable? Whether it works on electricity, whether it needs a battery? Can we take it in flight? These are common questions that people will ask. But answer to most of these things, yes, we can do everything. The machines have become very soft, lightweight, and they can be used. But that counseling by a doctor is very important. Let's hear from Sharda
So
about
there's a fun
further
fact here.
details.
So Dr. Sullivan got his idea of CPAP from a vacuum cleaner.
Oh wow.
Yes.
Wow, wow.
So he saw the vacuum cleaner and then he realized that the suction of the mechanism behind the suction can be used as a suction on the face.
It's like a blower. Maybe I think he was using vacuum cleaner as a blower from the other end. Even we can do that, and that blowing might have given him the idea. So what are these APAP, BiPAP, CPAP?
So this APAP, I think, is the new machine which majority of us are prescribing to every patient nowadays.
yeah.
So CPAP needs a fixed pressure or a pneumatic splint that has a one constant pressure to relieve the obstruction. Whereas an APAP has a wide range of pressure from 4 to 20. So it helps in detecting obstruction in real time. So in such cases where patients do not want to undergo a titration study going to a level 1 sleep lab, most of the patients are advised on using a APAP machine, but it works just like
So
CPAP.
APAP is like as per the need of the patient, how much is the block there. The machine senses that. It has a algorithm, it has a software. So it will pick up the need and accordingly it will increase or decrease the pressure. So it is a servo mechanism. It helps the patient better. It's a
While
in BiPAP,
BiPAP is used majorly for overlap patients like OSA, COPD patients or obesity, hypoventilation patients. So such patients use BiPAP where there are two pressures. One is the inspiratory positive airway pressure and the expiratory positive airway pressure. Expiratory positive airway pressure works just like the CPAP, which helps to open up the airway, whereas the IPAP, where it gives you a good tidal volume for your inspiration.
yeah. So those who cannot breathe well, it's like a support to them also.
So there are a lot of patients coming to us with that I am not able to tolerate BiPAP. I do not want to use the BiPAP anymore. So what exactly are the problems
BiPAP or CPAP, both. Yeah.
that they come with is that they come with claustrophobia, eye irritation, nasal allergies.
First and foremost, this concept of any device treating your disease is not acceptable. People want tablets, they want prescription, they want easy things. One thing which I ask them that, can I see or can I have a good vision without this spectacle? If there was a tablet as a substitute for this spectacle, I would have taken the tablet only. I wouldn't have used the spectacle. So not all diseases in this world can be treated by taking tablet. There are something which requires some instrument, some device to be supported. So this is how we can kind of explain or argue with our patient who is not willing to use a CPAP. So that is where maybe half the battle is won once they have accepted it. Then there are genuine issues which Dr. Sharda is narrating, and then how to solve them also she will tell. Yeah.
So if the patient has claustrophobia, he's saying that बहुत जोर से हवा आ रहा है, then if the patient is using a full face mask, you can ask him to maybe use a nasal mask so that only the nose is covered and not the full face. Eye irritation is another.
Or even the pillow or that or
nasal pillow which goes inside
where
your
the nose is not covered. So these masks are actually available at the counters. You will please see them after we complete.
Dry mouth is major problem which most of the patients complain of, where they're continuously having some throat irritation or some throat infections. So for such patients, there's something called as a humidifier that comes along with the CPAP machine, where the humidifier actually moistens the air, and so it can be used in such cases, as well as a chin strap can be used so that the mouth breathing is minimized.
Yeah.
So apart from using the CPAP, patient needs to be acclimatized to the fact that they need a CPAP machine. So how do you acclimatize a patient? You desensitize the patient with telling the patient
friendly with the device.
You ask him to play around with just the mask. Ask him to hold the mask in front of his face.
So the machine is to be used at night basically. But then what we are trying to say is that you make them handle the machine during the day also when he or she is awake and actually experience how the air is coming through the mask, and that is the desensitization protocol.
Where in the early morning hours you just ask him while doing your routine activity, just hold the mask without getting it attached to the machine, or use it while having naps in the afternoon and then finally use it at
even
night.
In the awake stage also you can just put it on and just get the feel of it. It's a little scary. They don't get and even with spectacles we all have gone through that. When first time especially as a child, when we start using spectacle, it is not a very comfortable feeling, but one gradually overcomes. So same thing happens with CPAP, and they also overcome, and these are the different kind of masks which are available, which you can definitely go and see there. And
so you start
this is
with
a
a nasal mask, nasal pillow or a nasal mask, and if patient has other issues with the mask, then you give other masks as well.
Yeah. The maintenance of the CPAP is very, very important. Especially there are the servicing. It's like servicing your car or servicing your AC also at home. So if a machine is just used without that, it tends to catch a lot of dust inside, and the efficiency of the device goes down. The simple thing which is a filter which is there, which is through which the air has to pass to make it clean. But these filters so often get so dirty because of the air and because of the dust in the air, and they become even black in color. So it should be white like this, a little on the browner side, but not black. So I ask my patient to even bring the machines to the clinic when they are finding some problem. Even after using CPAP, sometimes they are not getting benefit. I ask them to bring the machine there, and once you just open the cover of the filter, you just take out a very dirty black looking filter. So this type of information has to be given to them so that they can take care of their device and they get the maximum benefit out of this. This is a compliance report.
This is a compliance report which you ask the patient to show you after using it for minimum of 3 months. So it tells you the number of days the patient has used the CPAP machine, what pressure the patient is requiring to relieve his obstruction, how much is the leak because of a very high pressure. So the leak should be less than 40 liters per minute. What is his current AHI after using the CPAP machine? If it has reduced well, then the patient should be told to continue the APAP or CPAP machine at the same pressure.
So this report is a good patient report. I think the AHI has come to 0.6. He has been using on an average for at least 6 hours.
8 hours. 8 hours.
It is. So and his pressure is reaching up to 10.7, 95th percentile. Accordingly, the minimum pressure also has been adjusted to 8. So these fine tuning has to be done by the doctor. You can ask the patient to get the machine to your clinic and get adjusted, but now they have a cloud function. So with help of cloud function, either your channel partners who have given the machine to them, or we as doctors also directly can monitor their data, how they are using, and we can adjust it from our end through the cloud function. So this is the level at which the companies have reached. Only thing, we have to take the benefit out of such instruments. You had some question. Insurance cover is a very tricky area. I think there is no clear answer. They are still not, I think, fully covering, but there are some companies which are in that process, and slowly, steadily we'll get it. But I think it's not, yes is not the answer to your question as yet. So, yes, sir. Dr. Iyer, he's one of the stalwarts in the field of sleep medicine, and he has done a lot of work about sleep apnea for last many years. Thank you, sir, for attending our event today. Can we have mic for Dr. Iyer? Somebody please keep a watch on.
I've been in sleep medicine last 25 years, exclusively practicing sleep medicine. Now this is very interesting session, Dr. Shikhar. I congratulate you, all the speakers, for putting in so much energy into this. Nobody talks about this. After so many years, I think this is the first meeting I am attending where it is devoted to OSA. Really, I have traveled so many miles in this. Some important points I would like to comment with your permission is that if you take an obese patient and ask him to show the photograph of his young age, he will be very thin in college. After that, he puts on weight, and aging starts at age of 30. So then all these things happen and they come to you at the age of 40. So sleep apnea itself causes obesity. This is not accepted. This is a fact that you are thin during your young age, you had a narrow airway, the genetic predisposition is 30%. So if you take history in family, that must have been covered earlier, I am sorry if I am repeating. That is family, I have got families who are using the CPAP. Brother, son, daughter, everybody. And the whole nice thing about CPAP, that you are protected against several diseases. And one of the important things in elderly is that the stage 3 and stage 4, which goes away with age, that returns to normal after using CPAP. So your growth hormone secretion increases, and thereby it reduces the insulin resistance and so many other things. But the problem in old people is compliance, that we have to sit down and do that. I'm not going into details. Then secondly, as far exercises are concerned, a word of caution, don't ask the patient to go to gym, because gym there are so many exercises, and I have had people collapsing in the gym after doing exercises. Because of the hypoxic myocardium, which is there in the night, it spills over during daytime, and early morning they go and do this exercise and they have gone to ICU. And some people have died in the gym. Then the other thing is that the ophthalmological complications, I don't know whether, I was a bit late, it was covered. There are several eye diseases which are associated with this OSA, and like floppy eyelid syndrome, we had one patient in Delhi who improved with CPAP, and so many surgeries were done to cure him from floppy eyelid syndrome. The second is glaucoma. We have shown improvement in vision by putting CPAP in sleep apnea with glaucoma. This is the first case report we have published. So improving vision, the patient was so stunned that there is no drug to improve vision. Then patients of diabetic retinopathy, I am happy to share that I first proposed this hypothesis in the world that hypoxic retina causes angiogenesis in retina, and this progresses to blindness. If you intervene during this process by doing a proper sleep study, and that is in level 1 study with CPAP titration, and convince him the retina will survive. This is also done across the world, but somehow it is not picking up. The important thing is that 85% of type 2 diabetes have sleep disordered breathing. This is never inquired in the history. If you ask any diabetic, do you snore? He will say, so I'm not snoring. Because snoring comes more in the REM sleep by the time wife has gone to sleep. So that is the reason why we miss these patients. If you treat the CPAP, if you put CPAP in diabetic patient, it improves insulin sensitivity and you can reduce the doses of the drugs. Then, once you're using the CPAP, don't keep any instruments behind the machine because air is being drawn from behind. If you keep some powder, some water bottle, something that it might hamper the functioning of the machine. Then, as far as you want to travel, I have had patients who go to states every month. They are carrying portable CPAP, battery operated, which you can use in the aircraft because you are not supposed to use this normal machine in the aircraft. So you can use portable CPAP and have a fine landing without any jet lag. Jet lag plus OSA is very bad because patient cannot go to meetings immediately. So therefore, you can use a portable CPAP. And finally, I would say that these drugs used to reduce body weight, like tirzepatide, these drugs also have ophthalmological complications as an adverse effect. So the drug may not be causing it. It may be the OSA there, which is actually leading to ophthalmological complications.
Great, sir. What you have
Thank you very
narrated
much.
is really the
Really great point, sir.
everything. You have so many years of experience, and you have added the best value to today's seminar by giving this authentic information with the authority that you have in this field. And we have your coming here has been really fantastic, and we are really grateful to you from bottom of our hearts. Thank you, sir. Thank you.
So
very
one
much.
thing was very nice. He said that the wife is sleeping when the husband is in REM sleep. So wives cannot complain, you know.
No, but अभी वो होगा. This snoring may start even early. Not every snorer has to snore only in REM sleep. So
Where the point taken was
But
that
at least
most of the snoring happens in REM
in
sleep.
the REM sleep. I agree. So let's go over the alternative. Okay, now we are almost 12.
We are,
12:15. No, we are not behind time. We are 12:15. We have time up to 1 o'clock. But we are asking our MCA, the catering service, to start the counters. We have brunch menu here, which is fairly filling menu. But we will be okay even if you just get up from the seat, go behind. Now we have developed a fantastic rapport with you. So even if you are having backs towards us, we know that you are listening. So we don't mind that please pick up your plate and start eating, because this program is up to 1 o'clock only. We may not be able to go beyond, but we have something more to share. So that let us use the time in the best possible way. Have food also and listen to the remaining slides so that we also get the satisfaction of completing everything that we wanted to share with you. So, Mr. Grandel, please start the open the buffet, please. Yeah. PFT.
So in PFT, you understand whether it is an obstruction or a restrictive airway pathology. So in patients of COPD, OSA, overlap syndromes, such patients are morbidly obese. They have baseline oxygen desaturations. They do not have a normal baseline. So in such patients, you need a level 1 study, firstly. Secondly, they are more prone to having a severe kind of OSA, like moderate to severe OSA, because of chronic use of corticosteroids, which they are already on. The chances of obesity also is more in them, as well as if they have associated cor pulmonale like features. There is a dependent edema, which at night, if they are in the supine position, goes up rostrally, and there is a narrowing of the airway because of the shift of fluid from the legs to the neck. So all these conditions cause a severe, moderate to severe kind of a sleep apnea situation. So such patients need to be treated with a BiPAP machine and not a CPAP machine.
There the PFT assessment
Assessment will help.
Anyway, let's go over the other alternates to CPAP. Because patient से हमें ये machine नहीं चाहिए, हमें कुछ दूसरा दो करके. Then what do we offer?
Thank you, Dr. Pushkar. Now we are just talking about probable alternatives to CPAP. Now patient is tried on CPAP. Patient is probably not compliant. He wants some other alternative treatments. What can we do? Look, one of the most commonly used is a mandibular advancement devices, especially seen in retrognathic jaws, where we forward posture the lower jaw. Okay, then we can use this mandibular advancement device with a CPAP. In mild to moderate cases, it works very well. Then maxillary expansion. Now maxillary expansion selectively used for maxillary hypoplasia works very well. Then we call this something called as a maxillary mandibular advancement MMA with jaw rotation. Okay, now this is kind of a brahmastra that we have been using, as especially maxillofacial surgeons, because what we do is we move the jaws ahead slightly depending upon whatever parameters that we have and slightly rotate it, which opens up the airway posterior to this joint, to the jaws. Very useful tool. Again, we can do maxillary mandibular advancement with genioplasty, just as we alter the muscles around over there, which helps us in creating a better airway. Now, if the patient has ankylosis, TM joint ankylosis, that's a temporomandibular ankylosis, we do TM joint replacement with maxillary mandibular advancement. This is where the other adjunct tools like CBCT scan, cephalometrics, everything helps us out, starts helping us out.
Dr. Samrat, I have one doubt here. So our patient, the first patient which we were talking about, started using CPAP machine. So now, do you think that these other are alternatives to this patient's treatment?
Not alternatives. This could be an adjunct. I always say adjunct. Nothing stands by their own. Everything has to come together somewhere. Okay.
So he may not be doing great with CPAP. Maybe you can add a MAD to that, and the combination will work wonderful for
yes, if he has a retrognathic jaw.
Retrognathic jaw especially.
If patient, now at the age of 58, no one wants to probably undergo a surgery for snoring. So then we probably just leave at that. Those are different things that has to be customized per patient. All these treatment plans has to be customized as per the patient individually. Yeah.
Sir, my question is that patient will always ask me, suppose I send the patient to you. Before I send him to you, he will ask me, sir, आपने तो बोल दिया कि I've got a retrognathic jaw. When I go for the surgery, will that surgery get rid of this OSA for me for good? You said it has to be customized. Many people have got aversion to CPAP machine. Many patients, they have got the machines just lying in the house in spite of spending 1.25 lakhs. They said, we just can't sleep with that. Forget it, you don't talk about it. So when they come to me for a retrognatic or a hypoplasic maxillary, what is the percentage of success?
Yeah. So the evidence says that if the patient has undergone probably a maxillomandibular advancement with jaw rotation, the percentage is a success rate of around 80 to 85% at an average with the evidence.
That's good. That's
a very good. Again, as I said, not all cases are. So we have to be very selective in what we do and what we, can we actually prescribe that? Okay.
This is how the MAD looks?
Yeah, this is how the mandibular advancement device looks.
So this is the attachment you put every day in the night.
Yes, this can be put inside the oral cavity.
Upper jaw and lower jaw.
So what we do is, I'll just come to it. What it does is, can every patient benefit from a mandibular advancement device? No. Indications usually mild to moderate sleep apnea, non-compliance with CPAP or an adjunct to CPAP. It works both ways. Mandibular retrognathia. Having said that, how to check for effectivity, as like doctor was saying? Usually what is important in this mandibular advancement device, the advancement should be around 4 to 6 millimeters, an average of 5 millimeters. Okay, we then customize that according to the patient. And the criteria for resolution, or if the treatment is working, is we do a sleep study, easiest way. AHI less than 5, doctor has wonderfully explained what is an AHI. AHI less than 5, or resolution of AHI less than 5 with resolution of symptoms by 50%. Or at least reduction in the symptoms. Then we see that this thing is working, probably. Now, we can use different, sorry, I thought someone, we can use different assessment modalities for checking the effectivity of MAD. Easiest is level 3 home study, sleep study, works very well. Now, possible adverse effects. Now, again, change of occlusion, there is a change of how you bite. That can happen because you're wearing an artificial device on the teeth. So teeth tend to move and try to adjust themselves. Temporomandibular disorders have to be taken care of, especially the muscular pain and TM joint pain that can occur simultaneously with it. Again, contraindications possible, maxillary hypoplasia or maxillary collapse in few of the patients, where changing the mandibular position is not going to help. Okay. Again, non-compliance. Patient doesn't want something in the mouth permanently. Fair enough. That can be a compromise. I wouldn't like something in my mouth forever. Claustrophobia. Patients may not just accept it.
Forever only for the night. It's not during the day.
Yeah, but still few patients do find it more possible. And muscular pain around the face. That's what I said. Temporomandibular, not arthritis, temporomandibular disorders, disc displacements and all. Okay. Now, what happens in maxillary hypoplasia, which we were discussing about a high arch palate case that I had shown, you would see that there will be a constricted maxilla and restricted tongue space and increased nasal resistance. Can you just point out if possible? Go to the first image. You could see this, the maxilla, if it gets constricted, it will impinge on the nasopharynx area and with a high arch palate. So that may have to be relieved somewhere. So we do a procedure called as a maxillary expansion. So you, again, the old case, the same case with a high arch palate, and there is compression on the sides. Now we've used the device to actually open up the gap. So if you could see the gap in between the front teeth in the second picture, sir. Second picture. Yes, just ahead, the teeth ahead. Yeah. You can see a gap there.
Yeah,
and
this gap. Yeah,
my orthodontist has moved this teeth around and we've got a nice U shape, which kind of relieves the palate somewhere. Okay. Sorry.
Bruxism, she is asking. Masseter hypertrophy and bruxism.
Sorry, I didn't hear the last part. What?
So, bruxism and muscular hypertrophy cases, mandibular advancement devices or CPAP machines, like, how can we use? Can you put some light on it?
So, again, in my experience, I have not technically used it on my bruxism patients or something, because I would love to solve the bruxism and TM joint issues first before I use any other devices, because that can aggravate these things. So I am very careful of those patients. That's why assessment is very important. A good point raised. Not as I said, not every patient is meant for a mandibular advancement or surgery or something, customization is very important.
Hello.
For CPAP also first only bruxism, bruxism.
I would love to do that, unless, if it's like severe, again, that's why our team is together.
Yeah.
That we need to sort those things out. Saying is like, should we address the CPAP first and then look at the
Dr. Shah,
bruxism
that's
simultaneously?
Any moment disorder patients like bruxism or any moment disorder, the CPAP relieves them of all these symptoms. So even if you use CPAP along with giving them the psychotherapy which is given in bruxism, both works as adjunct.
Hello.
Because sometimes in bruxism we give different types of guards and everything also in the patient's mouth. So CPAP can be used
The
along
masks
with it.
can be changed. So instead of a full
Guard
face,
for the teeth.
but instead of the mask, you can use a nasal mask. You can use the guard mouth, because even in other patients, apart from bruxism, like other conditions where the patient is not obese, is a thin young patient, you can use CPAP and MAD both. So in the same way, bruxism can also be treated similarly.
So I would like to add something here. I specialize in TMJ, orofacial pain and dental sleep medicine. So with regards to bruxism and temporomandibular disorders, I mean, they are concurrently found in all cases which have mild or moderate sleep apnea. Okay. So if you are giving appliances which are given in patients which are having bruxism, then they are not going to be comfortable with the appliances like MAD, because they already have dysfunctions in the TMJ. So as doctor specified, we have to treat the TMJ disorder first. And bruxism, although it is like a moment disorder, but it is mainly related to sympathetic activation which happens due to sleep disordered breathing. So once you clear the sleep disordered breathing, that sympathetic overtone is reduced, and that itself reduces the bruxism.
Fantastic.
Yeah.
Beautiful.
So
Explained.
such value addition is always welcome. This is how we even enrich our knowledge. Now, just quickly going through this.
No,
Now
sir,
we've used
just this bruxism. Even I wanted to ask a similar question. I'm sorry, I'm prolonging this. Yeah, I'm sorry, I'm prolonging this conversation about bruxism. Even I wanted to ask, like this bruxism in children also, like the child is grinding teeth so hard that the mother feels कि I don't know ये बच्ची सोती. I have a 8-year-old girl. सोती भी है कि नहीं कि सुबह स्कूल के लिए उठती नहीं है, and because she's grinding it so hard, we are also not able to sleep. So I have sent the child. बहुत बार I tried to use various aspects. कुछ नहीं फर्क पड़ा ना कि अभी डेंटल के पास जाओ, कुछ वो गार्ड देते हैं, वो गार्ड देंगे तो ठीक हो जाएगा. So is this also like, I mean, I didn't have any knowledge.
That is a part of the treatment.
Sorry?
That is a part of the treatment. Mouth guard, using a mouth guard is a part of the treatment, but actually
Would this
bruxism
also be something related
No,
to
but
like
the child
Can I
should have
add?
been investigated for
Can
sleep
I add?
apnea also.
Can I add?
That is what I.
Probably
actually,
it was not
bruxism
done.
is a survival reflex.
So
it is
just
because of
just a moment, because it is dental related. So when a child has issue with regards to bruxism or grinding of the teeth, and we suspect that it is happening because of sleep disordered breathing, the first thing is to correct the airway. That is to correct the growth, because child you can correct the growth, adults you cannot correct the growth. So anything which will correct the growth in the adulthood, that will be eliminated. So appliances, orthodontic appliances which expand the maxilla, which expand or change the position of the mandible to correct the joint position and change the position of the mandible forward, they will correct apnea also, which is developing in the child, and correct the growth deficit also, which is happening in the child. So such patients should be treated orthodontically for growth modification. So it will correct the grinding also, it will correct apnea. And so in orthodontics, that is branch of dentistry, we expand the maxilla, we grow the mandible forward.
Again, we might just run short on the time that we have. We could keep this discussion at a slightly later stage, if you don't mind, please. Sorry to interrupt. Yeah. So we have something called as a maxillomandibular advancement with rotation of the jaw to increase the airway space. Okay. We have this patient over here. You could see a retronatic jaw, sir, can you just point it out? You can see the airway in the lateral cephalogram. It is slightly less. And this is the dentition which is present over here. Orthodontic surgery done, we can see both the jaws have been operated on with a slight rotation and a genioplasty, where we could actually see that the airways opened up. Okay. Similarly, again, this patient, if we do the CBCT scan, this is a pre-op and the post-op with the volumetric analysis. Now, can you just play the video for them? This is what I was talking about, projection planning and virtual surgical planning that we have, this modality that we have. This is a patient with a facial asymmetry where we have actually done and simulated the surgery, and you could see a projection planning which helps in correcting the symmetry for this patient. And when you see it from the side profile, it will come eventually. You can see it from the side profile. So if you could just point it out to them, you could actually see that we have made this kind of a difference.
So we can think out that this jaw, as it was here, now it has come in front.
Yeah, that's okay.
The next slide.
Next slide. Sorry. Again, I use this CBCT scan even to check for you can see the difference in airways.
The compromised airway.
Now, one of the patients over there where we had done a bi-jaw procedure.
I have also started picking up now. This is a narrow airway, na?
Yes.
And now it has become big so much. Wow.
Now, again, the same old patient that we had seen here, we have done this procedure. This is not technically a OSA patient. This was slightly older patient. We had not evaluated that OSA had picture, what didn't come into the picture, but something which can help us out to understand that we've actually corrected her facial profile, and probably because we've not evaluated this patient for OSA has also helped her to solve the OSA issue. I'm just assuming in this case. This is again a projection planning. If you see, that's the patient with ankylosis, or the patient doesn't have a TM joint at this point of time. You could see at the angle of, in the red picture, you can actually see the angle, how it is angulated. The jaw is going downwards and the airway is narrow. But if you look at the second picture over here, we can see that if you've done a TM joint replacement, we've done a mandibular maxillar surgery, and we can also look at that the airways increased as a byproduct. Okay? So next. Now I'm just handing it over to Dr. Vidit to look into the soft tissues.
Yeah, so we come back to the same child. You can see clearly in the X-ray of the nasopharynx or the soft tissue of the neck, where the adenoid is occupying almost 2/3 of the choana or the nasopharyngeal junction. So for this patient, an adenoidectomy plus minus a tonsillectomy will definitely relieve the patient of sleep apnea symptoms. Coming to the nasal aspect of things surgically, so as we discussed the static levels of obstruction, you have the nasal bone deviation for which the septoplasty is performed to correct that, and you have the inferior turbinate reduction, which also helps in relieving the patients of these symptoms. The key takeaways for nasal procedures are very easy. So nasal procedures are always in snoring are pivotal, and they are again an adjunct to the management of OSA and not the only treatment solution. Evidence clearly suggests that nasal surgery may not reliably improve the AHI in patients with OSA, but it often improves the daytime sleepiness, the subjective sleep quality, and snoring intensity. So in short, we can say that post-nasal surgeries, the CPAP pressures decrease by almost 2 to 6 centimeters of water, and the CPAP adherence and optimization improves from 40 to almost double 80% in CPAP intolerant patients.
This is a very important message.
Very, very important key takeaway for most patients who are non-compliant or intolerant to CPAP.
CPAP therapy may not be completely avoided by doing the procedure, but the patients become more friendly to the CPAP, and their compliance definitely increases.
Now coming to the throat or the oropharyngeal interventions, we had seen the DICE video. So the palatal or the pharyngeal surgeries we opt for the patient are the UPPP, that's uvulopalatopharyngoplasty, tonsillectomy, of course. You have the expansion sphincterpharyngoplasty and the palatal stiffening procedures. UPPP, as the name is very clear, it's uvulopalate pharyngsplasty. The only drawback or limitation with this procedure, and that's why it's almost become obsolete, is that it only addresses the anteroposterior or only the front and back pharyngeal wall collapse. It doesn't address the lateral pharyngeal wall collapse, which we pick up on the DICE. And it's a very morbid surgery with lot of post-operative pain and post-operative dysphagia. So a modification to the UPPP is the expansion sphincterpharyngoplasty. As one can clearly see in this DICE image that UPPP cannot address the lateral pharyngeal collapse, and that's the reason where the expansion sphincterpharyngoplasty comes in play. The indications mostly for surgery are again lateral wall collapse in mild to moderate sleep apnea patients. The less invasive techniques of the oropharynx which patients would prefer would be palatal stiffening procedures. The ultimate goal in a palatal stiffening procedure, either with radiofrequency or we can do the cautery assisted palatal stiffening, is in the radiofrequency approach, there is a reduction in the soft palatal tissue volume and highly beneficial in mild OSA patients. And in cautery assisted palatal stiffening, because of the elevation of the soft palate, which results in fibrosis, the patient benefits. Coming to a very huge aspect of sleep apnea, which is the tongue-based collapse, which we have always been talking about, the tongue. The tongue-based interventions are the radiofrequency ablation or the coblation-assisted tongue-based volumetric reduction. Suppose the patient comes to you saying that we don't want to opt for any surgical intervention like a radiofrequency or a coblation-assisted volumetric reduction, then the options we have for that patient are minimal to non-invasive to a large extent, where my friend Dr. Samrat can help us with the mandibular advancement device and the indications for a tongue-based collapse. Those patients who prefer a mandibular advancement device is a younger population, non-obese, and who don't want a surgical intervention. And the hypoglossal nerve stimulation is a very upcoming and novel technique in a tongue-based collapse situation. The indications for hypoglossal nerve stimulation are the BMI less than 32, where you have moderate to severe OSA, which is detected on polysomnography, or patients with multiple comorbidities and those in the elderly age group. Now to just summarize the entire management aspect for patients for sleep apnea, the first thing we do is diagnose the patient by doing a simple PSG or a polysomnography, that's level 3 sleep study. Then if required, we may opt for a CBCT to understand if your clinical correlation is not really matching with your sleep study findings, and assessing the airway when you are assessing a multi-level obstruction. So doing a DICE, the drug-induced sleep endoscopy, surgery if indicated and if the patient is willing, plus minus the CPAP. Obviously, these patients require repeat sleep studies to follow up their symptom improvement, and long-term monitoring is essential in this entire disease of sleep apnea. Yeah, I'll hand over the case again.
We have almost concluded this case.
Absolutely.
And I thought we'll take a summary of this case before we move ahead. So, we doctors need to be definitely, you all will agree to these statements which I'm going to make now, that we doctors need to be more aware of sleep disorders, especially the OSA. We need to have high index of suspicion for OSA. Unless we suspect what our mind doesn't know or our eyes don't see. So we have to have that awareness. We should start asking sleep history, without which we will not pick up the diagnosis. We have to make efforts to sensitize people to help to diagnose that they snore, they choke at night, their daytime sleepiness, OSA, for which they must come and ask help from doctors. And they should also know that there is all these things are linked to diseases like hypertension, ischemic heart disease, etc., and motivate them to seek medical help. Lifestyle modification with weight control and exercise forms the cornerstone of management of sleep apnea. PAP devices are the most effective non-invasive modalities of treatment. Counseling and ongoing medical help ensures better CPAP compliance. There are options to CPAP like mandibular advancement device and surgical treatment of bones and soft tissues in correctly selected cases can provide a great adjunct to the medical management. So I propose these statements as a takeaway of this meeting, and if everybody agrees, we want rise of hands that these sentences are all can be accepted as the conclusion or rather the takeaway of today's meeting. We have actually done with the first case, but we want you not to go away with the feeling that all the sleep apnea patients are only hypersomnic or जिनको नींद का वरदान है. There is something which is called मुझे नींद ना आए ऐसे भी पेशेंट होते हैं और वो एक हमारी one more case we have. I think we have some time. Food is going on. Those who have yet not picked up the plates, please go and pick up. Dr. Chopra, आप जाइए पीछे. Dr. Anil, आप खाना लेके आइए.
Get food after 1.
हाँ खाने वाले नहीं है.
We will not get food after 1.
नहीं, we will not get food after 1.
So
the hall is only up to 1 o'clock.
Okay.
हाँ, but we want to utilize the time, so that's why we are trying to.
One small question. The radio frequency ablation will take care of the collapse of the pharynx laterally also.
It will take care of the collapse provided the patient is a mild case of sleep apnea which is established.
Mild to moderate.
Mild to moderate can be tried. Moderate can be tried. Mild definitely will help.
Okay.
Okay, so now
so case 2.
Case 2.
Rapid fire. Right?
So 48.
We are all now learned in OSA, so we can do rapid fire.
So 48-year-old female working in finance, she comes with complaints of tossing and turning in bed and early morning awakenings, snoring, daytime fatigue, lack of concentration and forgetfulness. She's a known case of post-traumatic stress disorder. What do you think is her diagnosis? Before examination, let's all get sensitized that it may be a case of OSA.
Yes.
On further examination, her BMI is normal and her Malampatti is 1. So let's assume this is an OSA case.
Yeah, we did the sleep study, showed an AHI of 10.
And the patient is started on PAP therapy, but the patient comes back to your clinic saying that नहीं हो रहा है, नहीं CPAP use करने हो रहा है. So what do you do? But we have ruled out all the side effects of her CPAP therapy.
So there is something beyond maybe sleep apnea or the standard sleep apnea that is happening. So
not all OSA is equal to obesity. We just wanted to tell you.
And not all OSA is equal to anatomical obstruction. There is something which is beyond that called as non-anatomical obstruction related OSA, and that is why we are showing this case.
So difficulty falling asleep, maintaining asleep or early morning awakenings can be a part of the insomnia symptoms or insomnia spectrum disorder. So a combination of a poor night's sleep and adverse effects during daytime can establish an insomnia diagnosis. So the causes of insomnia can be varied. It can be stress, anxiety, depression, poor sleep hygiene, chronic pain, neurological conditions, irregular sleep schedule, medications, environment, and caffeine or nicotine alcohol use. So is this a case of insomnia or is this OSA? What do you all think?
You have already demonstrated PSG showing the
AHI is 10, AHI. So what we are trying to say is that it is probably not a clear-cut only anatomical. Otherwise, with AHI of 10, the CPAP should have helped the patient. Why is CPAP not helping this patient? So what are we missing? That is what this case is all about.
So there are 3 endotypes.
Clear-cut insomnia only then in that case.
No, there is something which is still more to that. Yeah.
So
Please go ahead.
There are endotypes of OSA which is divided into the PALM classification, where PALM P stands for the passive pharyngeal anatomical collapsibility.
That was our first case. The first case was fitting in this P, but there are 3 other which also can be the different varieties of sleep apnea, which may not be responsive to CPAP that well. So what are they then?
So A is the low arousal threshold, L is the high loop gain, and M is the decompensation or not the genioglossus muscle activity is not fully working or it's not fully activated.
So in low arousal threshold, it is the brain which is hypersensitive actually. So it is the brain is unnecessarily giving a quick response. So even there's a little drop in the oxygen saturation also, the brain awakens the person. The brain just doesn't allow. It's an over alert brain. So over alert brain also has to be managed in a particular way. And these patients will actually, as far as therapy is concerned, may respond to sedatives. So some of these patients may actually respond to even sedatives and not only giving CPAP. There is another entity that is high loop gain. Can you speak about that?
So high loop gain is where there is a chemosensitivity, or when there is a hypercarbia or hypoxemia.
Over
responsiveness or even a small disturbance causes.
So even if there is a little increase in CO2, the person
system
will
gets alerted.
alert, and then patient over ventilates, and because of over ventilation, the CO2 suddenly drops and the patient stops breathing. So there is excessive reactivity as far as CO2 is concerned in these patients.
And then there is
Decreased muscle responsiveness. The brain is sending a signal that your muscle has to tighten and the tongue has to get retracted, but the tongue is just not doing that.
There is not enough dilation,
happening there.
genioglossus.
So this high loop gain patient actually respond to supplemental oxygen or giving a drug called acetazolamide. So we just want to sensitize you that it is not only CPAP. There is something beyond that, and for which this a detailed analysis of every OSA case is required, because we may be missing on something which is not getting picked up.
But how oxygen supplementation will help when it is so brain responsive? It is the patient is not going into hypoxia.
Yeah.
Patient is only getting awakened because of the
hypercarbia actually.
It's hypercapnia you are talking about. But that also will be very transient.
Yeah.
I don't think you get so fast awakened by a hypercapnic spell so fast.
But that happens in these patients.
Unless the hypothalamus is very, very overactive.
These are oversensitive carotid body sensors which are there. They are oversensitive. And by giving them oxygen, the receptors calm down. It is like a calming down effect on the receptor. And their reactivity to CO2 also decreases. In fact, when we give acetazolamide, what happens is that it causes metabolic acidosis and it brings down the CO2 level in the body to some extent. And that's why those jerks in the CO2 and related respiratory fluctuation doesn't happen to that extent. So these are very intricate issues. Just don't want to go into a complicated, but
we should keep it in mind.
There is something beyond CPAP that we have to
something new.
That is the only message. And this is UARS. That is another thing which is we were talking initially about the RERAs and all that we talk. So what happens is the increased resistance to airflow in the upper airway may be happening to some patient, and extra physical effort that is needed to overcome this resistance, which causes an arousal that is called as RERA. So this is also peculiar to certain endotypes, certain type of persons who are responding. Their treatment, if you see the sleep report, their AHI may be normal, but their RDI is abnormal because they have RERAs. So that's why we need to read their sleep report in detail. It's not only AHI. There is a number which is next to it is RDI. That makes a difference. And these patients are often lean and thin. They may have excessive daytime sleepiness, brain fog, chronic headache, and especially they may have dysautonomia. So this is one symptom where they can have cold extremities, or that is called as postural orthostatic syndrome. So these are the patients who get this syncope, vasovagal syncope we call them, as they may actually have UARS. So this is another take home that we want to give. This is interesting field very much. And they may have vague symptoms like IBS, chronic fatigue, fibromyalgia, where we do not have answers. We sometimes just label them as psychiatric cases, but they may be actually underlying OSA. And their treatment is almost similar to sleep OSA only, though they are UARS. So anything more you want to add to this?
We can even try MADs for such patients.
MADs also work. Yeah, MAD is a simpler version. And this is just the last case which very close to my heart, because I work in Vadia Maternity Hospital also. I go to Lilavati, Shushrusha, Raheja and Somaya as my main attachment. My clinic is at Dadar. We have also started a sleep clinic from my place as well as Dr. Vidit's place. We have been already distributed the pamphlets of that. But because of my attachment with Vadia Maternity, I see pregnant women patient there, And this is one case which is habitual snorer, choking spells on supine. All this is on inquiry. Actually, the patient has come to with hypertension, the pregnancy hypertension, and she is obese also. She has obviously edema feet. On examination, I found that she has short neck. But all these history of daytime sleepiness, choking, obviously came on direct inquiry. The patient never came up with that. So again, stressing the importance that unless we ask for it, patients are not complaining about all that. What happens in pregnancy and hypertension, if they have, it is because of OSA, there is episodic hypoxia, which is again causing sympathetic activation, inflammation, placental ischemia, and this all will lead to endothelial dysfunction, hypertension, and preeclampsia. Obviously, preeclampsia causes water retention. There is upper airway edema, which further feeds the obstructive sleep apnea and goes into a positive feedback loop, and this gets worsened. So there are many other things which can happen if there is OSA in pregnancy. It can cause preterm, it can cause cardiovascular morbidity, gestational hypertension we already spoke about, gestational diabetes can happen, and even the fetal wastages are not uncommon. So that is all we have to remember. So my take here is that offering CPAP therapy to such women who are actually having sleep apnea in pregnancy can make a huge difference to the maternal and fetal outcome. That is what I have been already documented in papers, though we are not very regularly following it because everybody has to be on one page. Unless we all really become aware about this disease and start following in the same way. Babita is listening. I want the gynecologists to follow this, what we are saying. This is all proven. We need to just go into details and start applying it to our day-to-day practice. So I think we are almost done. Thank you so much for your patient hearing. We all thank you. Thank you, Dr. Vidit, Dr. Samrat, Dr. Sharada. Our association has been fantastic. It will go a long way because we have launching the sleep clinic on this auspicious day. Today we are launching our sleep clinic. We have my clinic we have at Dadar as well as at Vadala, where Dr. Vidit has his clinic, but we are all going to be together on these cases of sleep apnea through our clinics. We have our appointment number also here. Dr. Sharda will be mainly handling our the main workforce, and we all will give the best possible support to all of you whenever you need. You all are already learned, aware about this disease, and you are growing. But unless we project it to the community, tell community, we have Dr. Mahesh Chitnis. We want our program to come on TV, Mahesh. So he is the famous doctor as well as the TV jockey or what you call who has conducted many programs on Marathi as well as other TV channels. So we have great people. We have Dr. Jayan Kandekar, who is a CVTA surgeon. He has also agreed that his patients do need CPAP. So we are really blessed. Today has been a fantastic day. Without our channel partners, sponsors, nothing was possible. We have presence from ResMed as well as Philips here. So we want them also to support and take this movement forward. Anything more, Samrat, you would like to add with it, Sharda?
I mean, that was absolutely a wonderful presentation. It's been an attempt to try and get everyone on board because I believe that sleep or OSA requires a multidisciplinary approach. Very, very, very important. I may be able to pick up things which Dr. Pushkar may not be able to pick, and Dr. Pushkar would be able to pick up those things, or Dr. Sharda would be able to pick up those things which I may not pick up. So coming together and providing the best possible treatment, healthcare, management, I think is the key. That's the takeaway home message. Sleep apnea, yes, but a multidisciplinary team wherever, and it actually works.
Mic to Madam.
Congratulations on the launch of your sleep clinics at both the places. I have a question that I would like you to address when you are, you started your sleep clinic. Where does sleep myoclonus fit into all this? And the other thing is that, in the COVID, we learned a few things. That patient lying prone did better in any obstructive airway problem. And we also learned that hyperoxygenation occurred. So, that is also something, because it's very easy to say, just put them onto machines and things like that. But these are two which we never expected, but we learned during COVID.
The prone position, madam, is absolutely, we in fact did not mention because that, but is the most, actually the key thing. The position therapy of sleep apnea, we actually missed out, I would say. Because in prone position, the jaw falls forward and the sleep apnea is significantly reduced. I think our COVID patients also got benefited with the prone position. Whatever happened at the lung level, I understand their VQ mismatches got corrected and all that is fine. But even their sleep apnea was getting corrected, I think. And that has significantly helped. In yoga, it is the Makarasan. In Makarasan posture, we lie in the prone position, and that is fantastically useful. So that is right. Myoclonus is to some extent natural also.
No, it is. We call it hypnic jerks.
Yeah, so it is not a disease.
It's a transition.
But
because Sharda had talked about the movements, in which can occur in your OSA, the sleep, movements in sleep. So whether, this can...
Dr. Rajiv Bhagwat, a very senior interventional cardiologist, is with us, and he has huge experience in managing coronary artery disease. Any blessings you want to give or you will send more patients to us? Your every cardiac case has to come for sleep apnea study.
Yeah, so I think it's a great effort on part of Pushkar and his team. So only a few lines. Patients who have coronary disease, especially with LV dysfunction, or who have cardiomyopathies. So these are patients who are at high risk of sudden cardiac death in sleep. So when you read reports, he died in sleep, possibly has obstructive sleep apnea and maybe undiagnosed, undetected component of CAD or cardiomyopathy. Because it's very simple. Once you have stress, you have adrenaline. Adrenaline, arrhythmogenic. So it's a vicious circle, especially chronic sleep. Chronic lack of sleep is chronic stress. Chronic stress is chronic adrenaline secretion. So that's the only thing, yeah. So I think correction of sleep apnea will go a great way to
authenticating the treatment, and thank you. We agree to what you said. Do we close? Yeah.
Sir, should all professional drivers should be screened for OSA so that we can prevent further accidents?
Can you repeat, madam, please? Sorry.
Should all professional truck drivers, bus drivers?
Yes, absolutely. They must be. They should get. But I don't think it is. Even I had one motorman coming to me who has been operating the train, the local train, and he is a sleep apneic, which I found out. But he was doing his job. So
mandatory in traffic license checkup, I think. Yeah, why not? See, you save accidents. It's important.
Then we will get 33% of the population getting diagnosed as
statutory warning on the license, like in cigarettes.
I agreed.
And osteoporosis and OSA.
Yeah,
somebody
we did
mention
osteoporosis.
How? What relation?
It's all finally related to the free radical injury, hypoxia. Our bone health is also
hypoxia and
yes.
Otherwise, no other relationship.
Otherwise, no.